You guys are now
You are in the
recording,
meeting
and Dr. Anderson, just let me know if you need anything else, okay?
Thank you very much. Appreciate it.
You're welcome.
Okay. Amber, do you want to share first, or should I? Amber, you might be muted. If you're talking, we don't. Oh, okay.
Nope.
Yeah.
Oh, here we go. All right. You want me to just kind of go through disclosures and start the introduction?
Yeah. Well, Julia just brings up a good point here. Maybe what we should do first. Why don't, before we get into the meat, excuse me, the meat of this presentation, maybe we could each just take a moment and introduce ourselves, and quickly say our name, what our role is, and if you are inclined, just a sentence or two about what brings you here to this presentation today. And then after that, maybe I can come over and do sort of our CME explanation and intro, and then throw it back to you.
That sounds good. Well, I guess Steve and I can kind of start and introduce ourselves. And so my name is Amber Cahill. I'm a assistant professor in the Department of Family Medicine at the University of Massachusetts Medical School. I'm a clinical psychologist by training, and I wear a couple of different hats, but I think the shortest way to describe what I do is I've been really focused on medical education, particularly in primary care. My training has been really focused on co-treating patients in primary care together with medical providers. And in that, when I came to UMass for a fellowship, I had not to that point gotten a ton of training in substance use disorders. Again, in the field of psychology, it's very separated, right? You specialize in that. It's not baseline sort of education. And I started training at the Barry Family Health Center for my fellowship, where I worked with Steve, Dr. Martin, and there was a significant amount of patients with opioid use disorder. So I kind of was unexpectedly put into this arena where I was treating substance use disorders, 50+% of my patients. That was a key part of what we were working on. And so I describe it as I had to do a lot of unlearning about what I thought substance use treatment looked like. And so I tapped into the wealth of information that is harm reduction. And I've been really focusing my academic work on translating harm reduction into a way of thinking about patient communication that really applies to medical education. So kind of training specifically prescribers, so medical students, NPs, PAs, and that's part of why I got connected with James and you all. So I've been part of the group that's been leading the Project Echo that I think someone is going to talk about in a little bit. So that's me. Very happy to be here. I'll pass the baton to my co-anchor today, Dr. Martin.
Hi, thanks so much, Amber. I go by Steve. I'm a different Steve Martin than you might be used to, and that's okay. And very grateful to be here. Also, we've had a chance to work, with James and Amber for years now. It's just been a terrific partnership. I'm really grateful. Your area of New York is very special to me. I live in Western Massachusetts, so I'm not too far off from your catchment area. And I first became involved. I'm a family physician and also at the University of Massachusetts. And I became involved with opioid use disorder early in residency in about 2002. My clinical practice, residency practice was at South Boston Community Health Center. And that area was already really under the weight of tremendous amount of heroin and OxyContin use and overdose deaths. And we had so little to offer people. And so one of the things that I think is most remarkable about medical care in the last quarter century is that we're actually able to help people live longer, better lives. who have opioid use disorder. And it's very powerful, and everyone in the Zoom can do it well. So look forward to getting to know you better, and thanks for having us.
Thank you, Steve. And although you're not the Steve Martin that people might be more familiar with, you are almost as funny and certainly more knowledgeable. So yeah, that's wonderful. Maybe next we could go with my Bassett colleagues and co-leaders here, either Dr. Sellers or Dr. O'Reilly. If one of you wants to go next, that would be great.
I'll let Dr. O'Reilly go first.
Okay, I'm Jenny O'Reilly. I'm attending physician in family medicine, and I do have my addiction medicine certification now, as well as part of the work we've been doing here. I work in our clinic in Norwich as the medical director, as well as our clinics in Sydney, Unadilla, and Green. And I've been doing this work for, I think we're over 3 years now. So I find it very rewarding, extremely enjoyable, and it's been a wonderful complement to our family medicine practice here.
So I'm Joe Sellers. I'm an internal medicine and pediatric trained physician. I've been here with Bassett Healthcare for 31 years. I'm currently the Bassett Medical Group physician executive. So I'm in charge of about 535 physicians, PAs, and NPs, and a few psychologists. James and I somehow inherited a project from our leadership to try to bring MAT into our medical group with funding from the state district program. And I think I was given this program to follow because I don't think anybody else was wanted it, and nobody predicted it to be successful. But because of our working with James and Jenny and other early adopters, and working with people from UMass, including the two that are with us today, we just flew through this thing, and it turned out to be like one of the best things I've done in my 31 years here. And we embarrassed all the other disparate projects. There were 11 projects. We were the one that had the most success, that was recognized by the State Health Department and by the State Hospital Association for what we did, and the one people talk about in the community. So it's amazing how a project it was kind of an orphan project, but it got the right people jumping in, and the right coalition with other organizations that brought us some expertise. And so hopefully today we'll bring some expertise to some more of our neighbors, and we will have similar that throughout the Catskill area, people will be talking about MAT and the hospitals and the medical people that are helping people bend the curve, save lives, and are finding this very rewarding work to be part of their medical practice. So thank you.
Wonderful. So I'm James Anderson. I've got a very similar path in many ways to Dr. Cahill. I am also a clinical psychologist. I also did my postdoctoral fellowship at UMass. More specifically, I did my postdoctoral fellowship at the same health center that Amber did hers, and where Dr. Martin is still based. And that's actually where I not only started to appreciate and learn about the power of buprenorphine and MAT to make a real difference in the life of patients, but also gained an appreciation for the fact that if, as a psychologist, one's goal is to affect as many parts of the population as possible, it is difficult to do that by seeing one patient at a time, an hour at a time. And there are many consequences of adopting that perspective as a psychologist. But one of them is a passion for helping all members of our healthcare and medical teams, from physicians to advanced practice clinicians to nursing and social workers and peer support, it really, really takes a village to wrap around a population, specifically but not exclusively those struggling with opioid use disorder, to move the needle and make a difference that is important not only for individuals but for the community. I have been very, very lucky to land in a system that was sort of prepared and resourced to try to make such a change, and very lucky to have Drs. O'Reilly and Sellers as colleagues, in the case of Dr. Sellers as a boss, to sort of support and move this work going forward. So we're going to talk in a minute here a little bit more. We're not going to go into great detail, but a little bit more about our project to date. But Dr. Sellers knows, Dr. O'Reilly might know as well, that I have a propensity to talk. I'm going to be mindful of that and stop right now and ask some of our other members to briefly introduce themselves.
I'll go quick. I'm Julia Reichel. I run the Rural Communities Opioid Response Program at Margaretville Hospital, and that grant, which is HRSA funded, is paying for this session. The idea is that all y'all get to know each other, help each other out, connect better, with the goal of reducing morbidity and mortality from OUD and SUD, opioid use disorder and substance use disorder here in the Catskills. I'm super glad to see you all guys here. My peer who I work with closely needs to go to the hospital at my hospital right now, so I have to sign off of this. But you're in the capable hands of Isabel and Susanna, my research assistants, and we will do more work soon.
Okay, maybe I'll play or moderator here and just kind of go down the line. Isabel, I see you up next on my screen. Would you mind introducing yourself briefly, your name, your role, and why you're here? I will unmute you.
Sorry, I didn't realize that you meant me. I think my internet's cutting in and out a little bit, but I will be quick. So I am one of Julia's research assistants, and I've been kind of working on promoting this workshop, and I'm working with, and now I'm really interested to learn more about opioid use disorder and harm reduction, because I'm learning. I've learned a lot by working with Julia, but I'm excited to learn more.
Thanks, Isabel.
Hi.
Next,
Sorry. I was just going to say I'm Julia's other research assistant working with Isabel and Julia here at Margaretville Hospital. My name's Susanna. I'm interested in going to medical school and doing rural med, so this is very interesting to me to just help the greater community out, and I'm really eager to learn more. So nice to meet you all.
Nice to meet you, Susanna. And we like to catch folks early in the career, so this is wonderful. Up next on my screen here, I see Pamela Dorr.
Hi, I'm Pamela Dorr. I'm an ER nurse at O'Connor Hospital. I'm the nurse supervisor down there. It's a small critical access hospital down in the Catskills. I've been there for about 15 years. And obviously this interests me, finding resources we need to help the patients we need to take care of.
Wonderful. Thanks, Pamela. I've got Jill up next on my screen.
Hear me?
We can.
Okay, good. So I'm Jill Katina, and I'm a nurse practitioner with Bassett in the Norwich Clinic, which is a small rural healthcare clinic. I work with Dr. O'Reilly as my collaborative, and I'm currently working on my X license. When I was a student, I did training with an NP who had his X license, and so this is just a natural progression, and so I'm excited to be here.
Awesome. We're excited you're here.
You want to see Emily? She doesn't have a here. You get 2 for 1 here.
Okay, a twofer. Hey, Emily.
Hi. So my name's Emily Hodak. I'm a family nurse practitioner here in Norwich with Jill and Dr. O'Reilly. I haven't had too much experience with Suboxone patients. I mean, with prescribing in my clinicals, I didn't have any preceptor that did it. But in the clinic, we have a lot of OUD patients, and it seems very rewarding to be able to prescribe and help people. So I'm working on my X license, and I'm happy to be here on this class.
Great, thank you. Next on my screen here, I apologize in advance if I say a name wrong. Some of you earlier might have heard that I can't spell. Apparently I can't read that well either, but I've got Jessica Salerno up next.
Okay, hi, can you hear me?
Yes.
Okay, sorry, my video doesn't work, but I am a nurse practitioner resident here. So I am a licensed nurse practitioner, but doing an extra year of education. There's a couple of us on the phone call. So this is a new program with Bassett for nurse practitioners new to family practice. I came from North Carolina most recently, and I did my education for my X waiver last year, but I've never worked anywhere that I was actually able to get my X license because I didn't have a collaborator. And so I've never actually been able to practice this. So since coming to Bassett, I have gotten my X waiver, and looking forward to just getting a refresher and actually being able to practice treating substance use disorder while I'm here. So I'm glad to be here with you guys.
So glad you're here, Jessica, both in this Zoom and more specifically at Bassett. We're really lucky to have you in your cohort. So the order is changing around on me here. Sorry if it looks different, but next now I've got Elizabeth Moore.
Hello, can you hear me?
Yes.
Hi, I'm Elizabeth Moore. I'm actually interested in starting a non-for-profit organization for people that want to live the sober life, and we want to help them pursue a career in the arts. I'm a small business owner, and we feel that we could help people maybe continue their sober life with successful careers. And I'm here to learn more about the opioid addiction and what a sober life looks like for them and their trials and errors of getting to that point.
I feel really lucky to have you and to have that perspective in this meeting. We know that we want people to be able to sort of stop or reduce use of full agonist opioids and heroin, but I like to say we get greedy. We want more for them than that. And so having somebody who is working to help them have something to do once they've turned that page is just so vital. So I'm really glad you're here. All right, so next I've got Tenzin Sangmo. I'm sorry if I said that wrong.
You said right. Hello everyone, I'm Tenzin. I'm also with Jessica in our nurse practitioner residency program. And I'm so happy to be here. Thank you for this great opportunity. I hope I will learn more.
Yeah,
Yep.
So you're one of the NP, you're in the residency program,
Yes.
right? The NP res.
Yes.
Oh, so thank you so much for
I'm with
coming.
Greg. Yeah. Thank you for having us.
Yeah. Okay. Next I have LJ Olivia.
Hello, can you hear me?
Yes.
Okay. I'm LJ Oliva, and I'm a physician's assistant. Been practicing about 42 years in Otsego County. 20 plus years were spent in clinical orthopedics as well as orthopedic surgery. So I spent a lot of time prescribing analgesics. The last 15 to 20 years, though, I've been with also with Bassett in the Department of Emergency Trauma Services, primarily in convenient care. And certainly see, although I'm not prescribing narcotic analgesics as much or rarely anymore, I do see many patients with OUD, and anything I can learn to better care for the patients that are struggling is what I'd like to do. And I'm very grateful for the opportunity to be here today to see and hear what you have to offer us.
Thank you for coming. Glad you're here. Next, I have Jane Fairbairn.
Hi, so I am actually probably the lowest educated person on your whole panel, but I work with the Shenango County Drug Treatment Court, and I facilitate a guided journaling program to help people as they are, of course, involved in treatment court, which is a kind of a huge load on their shoulders, but I try to use their experiences with addiction in a positive way to help guide them towards a sober life. And because I don't have any true training in psychology or medicine or anything like that, I'm kind of every opportunity I can to learn something more, I use. So I'm trying to not screw people's lives up more than they already have experienced, and kind of just try to be a cheerleader for them as they work their way through towards a sober life. And I experience along with them a lot of their hiccups and their setbacks. Most of my people so far have more of a meth addiction than an opiate, or opioids, but they're starting to come into my fold more and more, and I soak up every ounce of information I can. So that's me.
I'm very, very glad that you're here. Thank you for coming and participating. Okay, I think next I've got Corinne Smith.
Hi, can you hear me?
Yes.
Okay. So I work in the Edmonston Clinic through Bassett, which is a very rural clinic. There are only 2 providers in this clinic, and nobody is offering Suboxone out of this office at this time for treatment. So I am currently working on my X license, and that's why I'm here today, to learn a little bit more about it, because a lot of my patients are going to other providers because I can't currently order Suboxone for them. So I'm looking forward to taking better care of the patients I have who also need some help with addiction.
It's hard to overstate how excited I am that you joined us here today. Thank you. I hope we give you something useful. So next, it's Kimberly S, and then the rest of the last name gets cut off on my screen here.
It's probably good that it's cut off. It's really hard to say. It's Saluka and Venberg, Lithuanian and Swedish. I am a new nurse practitioner in the family nurse practitioner residency program with Bassett. I actually am from the area. I have lived near the Delanson Clinic for about 10 years now. Prior to that, I lived in Schoharie. And I'm here because I'm working towards my X license. I definitely was really surprised when I did my pediatric clinicals with Bassett, how many kids were without parents because of substance use disorders. I was fortunate enough to have 2 preceptors during my clinical training that did MAT. One of them was an internist with about 50% of his practice. That was what he was doing with them. So I do have some experience with it. And I think it's a really important service to be able to offer our patients to kind of mitigate the risks that they have with their substance use.
Wonderful. So glad that you're here.
Thank you.
Next, I have Joanne's iPhone.
Hi, that's me. I'm Joanne Carey. I work with Bassett for the past 10 years in emergency med and also with LJ in the convenient care. And really, I just want to get a little more information on, because we are seeing a lot of patients coming in on Suboxone, and we don't necessarily prescribe it in the convenient cares, but I guess it's something we could consider if we have a patient who does come in, and something we can discuss amongst ourselves if it's something we want to go down that road. But here's where we starting point to get some information.
Figure out if you even want to start going down that road.
Exactly.
Yeah. Well, I'm glad you're here. Next, I have Jeff Cook.
Yes, good afternoon, everyone. My name is Jeff Cook. I'm sorry I don't have video on my Zoom conference today. I'm a new nurse practitioner. I'm in the family nurse practitioner residency with the other three ladies who you've met, and we're have Greg. Riss is our director, doing a real nice job here. I'm new to Suboxone treatment. I'm working on my X license like everybody else. I'll be working 1 day a week in Sherburne and with Dr. Haswell, and they have a pretty active Suboxone treatment plan there. So I look forward to learning things in the program today and next week, so I can carry on and start seeing patients in the Sherburne Clinic with Dr. Haswell.
Wonderful. So glad you're here, both in the Zoom and at Bassett, Jeff.
Thank you, sir.
All right, I've got two more. I see Sheila Johnson. Sheila, are you there? Okay. We'll give can circle back to Sheila later. And last but certainly not least, I have Michael Mott.
Yeah, hi. Let me get this thing going.
Michael, I think you muted yourself.
There you go. Sorry about that. I'm an intern with Janine Poland, and she works with Suboxone, and I'm in school for social work, clinical social work right now.
Wonderful.
That's it.
Thanks for coming.
Thank you.
Okay. So what I want to do next here, I want to start with something that might be important to some of you. I'm going to share my screen here. Okay. I hope that you all can see a slide titled Claiming CME Credit. For those of you that are interested and for whom this applies, this presentation, as well as the 4 hours next week, has been accredited by Bassett as eligible for CME. As you can see, we're in a 2020 COVID world. We have previously done these trainings in person, but like so many other things, it is electronic now, and so is our process of claiming CME credit. And so what will happen is you'll get emails from a website called My Evaluations, and it's going to prompt you to create a username and a password. Once you have done that and your account has been confirmed, you've got one of two options to be able to access the evaluation form, which is your key to be able to get the CME certificate. You can either download the My Evaluations app and scan a QR code that will be present in that initial email, or they will provide you with an 8-digit code that you can enter manually to confirm your attendance. This will give you access to the evaluation form. You fill that out, and it will link you to a certificate for CME. We're able to offer 4 hours for today, an additional 4 hours for next week. Any questions about that? Okay. If questions come up about that later, let me know, and we'll do our best to answer them. Okay. Well, I'm going to go quickly through this, both in the instance of time, and also I think that we touched on a number of these things. I do think that it's worth sort of highlighting again, in addition to sort of the readiness of the organization and having some real stalwart clinical leaders here. One of the things that was sort of important in getting this kicked off was a state initiative called DSRIP, or Delivery System Reform Incentive Payment Program. It's a mouthful. This is a program designed generally to encourage Medicaid reform, to make it both more effective and efficient, both for patients receiving the services and for the population at large, looking to reduce ED admissions, reduce spending, while also improving quality all at the same time. So I would add that in addition to some of the things that Dr. Sellers touched on already. We got some brief anecdotes already, but I think that, I mean, Dr. O'Reilly might as well, but I'm pretty sure that Dr. Sellers had something else that he wanted to share for the group here in this section.
Yeah, so I just wanted to share the story of one patient out of dozens and dozens that I've treated, and out of the 800 plus patients our organization has treated since we started doing Suboxone. And the reason I want to share this fellow is because I just look forward to seeing him in clinic every month. He's such a great guy, and he's really turned his life around. So Justin is 32 years old. When he was 15, he started smoking, first tobacco, then marijuana, started drinking alcohol. After high school, he got a job in construction as a laborer, and he'd get aches and pains from the work, and his other coworkers would sell him opiates to take, first as oral dosing of opiates, then snorting, and finally injecting, to where he was on a regular daily self-injections of opiates. When he came to me 3 years ago as a patient, I reviewed his record in the EMR, and I saw that he had been in the ER over the last 3 or 4 years with a hand injury from punching a wall, with a head injury from a fight and altercation with a coworker. He had been into mental health care with anxiety, and then had been in primary care with impotence, probably related to anxiety meds. And he had had at least 5 trips either to the ER or to primary care with unprotected sex resulting in STD exposures. But he came to me, and we started on Suboxone. He already knew his dose because he had been buying Suboxone on the street for when he tried to clean himself up. He was unemployed, was living with his grandmother, and had a series of broken romantic relationships, but was on his own at this point. But I started him on the Suboxone dose that he told me was working for him. That's pretty easy to have patients. How many of our patients actually experiment with blood pressure medicines or blood sugar medicines before they come to see us and can tell us what works? It's amazing. So I've seen him once a month now for 3 years, and in that time, he has had a urine that has confirmed compliance with the regimen each and every time. He's developed a new romantic relationship and has repaired relationships with family members and others he had harmed along the way. No more ER visits for fighting, no more STI visits. He actually got a union job in a union training program, and then a union job, and now he's just recently been promoted to a union foreman in the plumbers union. He's bought a house. He and his significant other are starting a family come February. And last week when he came to see me, we started talking about what's beyond Suboxone, what's beyond buprenorphine, and we started a weaning process. So how many patients do you see every day in your practices, and how often do you have this good a story? So here's a 32-year-old with a life-threatening condition who now has gotten his, not only that condition under control, but his life in order and moving in the right direction. He is happy. He has plans for the future. He's hopeful. And it's just, in the healthcare world, stories like this are, why we go to work every day. So just wanted to share that to get us started.
Thanks, Joe. Get back to my share here. Jenny, do you have any brief anecdotes that you want to share before we move on?
All right, I'll give the one quick story. I'm sorry, Jill and Emily, they've heard it before, but we first started this treatment here 3 years ago. I grew up in the area where I practice, and I graduated with about 74 students from the Oxford High School, and I know of at least 6 classmates who have passed from overdoses from that very small high school over the last 5 or 6 years or so. So we were looking to make a difference in our community. I think one of the things that we experienced, which everyone probably has experienced in their office, is that staff buy-in is sometimes a little difficult and the longest part of the process. So we're ready to treat our patients, but they're worried about additional work or disruptive patients or other issues it may cause in the office. So we did a lot of work for staff buy-in here, and then we got to the point we were waiting for a patient that we could make a big difference for. We'd taken over prescribing for some of our established patients who are already on Suboxone, but we're really looking for let's do something and make a difference. And we had a gentleman come in who was older. He started with a benzodiazepine addiction after his toddler was run over by his friend in front of him in a driveway many years ago. And she did not make it, and he had significant PTSD and anger issues. Started with benzos from a prescription, was cut off, transitioned to opiates on the street, and then had ended up in the absence of an income or any money on heroin. He'd had several overdoses and had been in the hospital. One of those overdoses, he woke up and his wife had also overdosed and had died next to him. And so when he came to, he realized that he'd also lost his wife. So he'd been in and out of the ICU, really big hospitalizations, blood clots, cellulitis, you name it. And it got out into the community that we were prescribing Suboxone. He was one of our patients and we talked to him, but he wasn't ready. And then one day in the middle of the day, his mom showed up with him here in the office in florid withdrawal. He'd been on his way to Binghamton to buy heroin and had decided that was it. He wanted help and he was done. And we brought him into an exam room, vomiting and with all the other symptoms of florid withdrawal. His mom went out and picked up a Suboxone script right down the street at a pharmacy, and we did a supervised induction right then and there. And he walked out of our office 2 hours later, upright, no longer vomiting, no longer sweating, smiling and excited about where his life could go. And he made it 1.5 years without using any other substances. He did have a relapse. Part of that is he's a Medicare patient, and Medicare, unfortunately, Part D does not cover Suboxone without supplemental insurance. So we've done a lot of work to get him back on his medication. But for the first time in 25 or 30 years, he went 1.5 years without using any substances and having a life again. And he's headed back there again. But it was just for our staff and our other providers who maybe weren't quite ready to think about this treatment to watch the difference between when he walked in and when he left our clinic, and his outlook on life, and spending some time with him and just hearing about what brought him to where he was today and what his life experiences were, and showing some empathy and some understanding. It was one of the most striking moments of my time as a physician. So I've been doing this here in Norwich for about 9 years, and that is a visit that I will never forget. So this is extremely rewarding work for certain. I will also say, I didn't during my introduction, I also trained at UMass and Barry under Dr. Martin here. And so we've all had a relationship for a while, and UMass providers have just been, all have been just incredible supports in starting this treatment. So.
Thanks, Dr. O'Reilly. As you can probably tell, both Dr. Sellers and Dr. O'Reilly have been just absolute stalwarts in not only doing this work, but real leaders in sort of moving it forward. And I'm just really grateful to get to work with each of them. What I'm going to do just really quickly here before I turn this back over to Steve and Amber, I want to just sort of highlight a couple of the data points that I think sort of illustrate some of the success that we've had to date. So we started this initiative, I think we had our first training, it was in person at the time, in collaboration with UMass in the fall of 2016. We started, we had our first prescribers start in the beginning of 2017 in conjunction with an ongoing sort of support, training, and collaborative group called ECHO that we might talk about a little bit more later. But a snapshot, we're now up to, with across all specialties within Bassett, about 90 clinicians who have obtained their data waiver. Most, but not all of them, reside in the primary care service line. About 60 of the 90 are within primary care. Others spread across psychiatry, the OBGYN department, and various other specialties. Across all of our specialties, from the start of our work until now, we have treated approximately 900 patients. Many of them, but not all of them, within primary care. Our focus, our emphasis for a variety of reasons has been primary care, but certainly it's important, I would argue vital, to have the infrastructure in other departments as well. We do know that specifically as it pertains to primary care, we have been very pleasantly surprised to discover that our treatment retention rate, which we know from the literature is one of the key variables in predicting long-term success for patients that are struggling with opioid use disorder. By success, I mean avoiding death. I also mean avoiding jail time, keeping jobs, staying out of the ER, all of those things. An important predictor of those things is maintaining in treatment for at least 180 days or 6 months. And we are pleased that to date, we're at about 82% of our patients that are staying in treatment for at least that long. And so that's a number that we're pretty proud of, and compares very favorably to what we see in the literature. And what I want to show here, we've actually had a few more patients since this graph was generated, but I think that it sort of makes the point. What you see here is from our start point in 2017 till about halfway through of 2019, you can see a real steady uptake of the number of patients that are not only being treated, but starting their treatment within primary care. So anybody that is represented on this list had their treatment begin in this time frame, and that treatment was initiated by one of our very own primary care clinicians. And so you can see from this chart here, it's been a steady and gradual process, and if this continued to the present date, you would see lines that continue in a similar fashion. So I'm going to turn it over now to Drs. Cahill and Martin, but I just wanted to give a little bit of a flavor of what this journey has been like for us at Bassett so far. We've certainly have more ground to cover, but we've made a lot of progress since we started this back in 2016. And while I think that we have a lot of special people here at Bassett, I don't think that we are so unique that other clinics or other systems can't have similar results if they are so inclined. And so with that, I will stop talking and turn it back over to Amber.
Awesome. All right. So I'm on full screen. Everyone can see that? All right. Awesome. So just real quick, I don't have any disclosures. Steve, do you want to, you can read, I don't know if that has to come with any more.
Yes, I disclose. Yes. And still working out of my closet at home, which I'm disclosing also.
Review of today, learning objectives. We're going to make these slides available too. So if there's anything that we kind of move through a little bit fast, we will make sure that everyone gets access to the slides. So, all right. I think part of what I want to do in this first part is really sort of set the stage. I think when it comes to talking about substance use disorder treatment, you really, I think you have to approach this with an acknowledgement and an awareness of the history, because it informs some of the barriers that still linger in the treatment system today, and still linger in the conversations and language used around substance use disorders. So I'm going to kind of paint a little bit of a picture around the history and some of the limitations of the current system that's going to allow us to kind of appreciate why we're all here, why it is that in my training it wasn't emphasized, and in I'm sure many of you on today, your respective medical training or education also didn't emphasize this. So we're going to put that in context a little bit. So again, history kind of repeats itself. So William White wrote a really comprehensive textbook on the history of addiction and treatment in the United States. And what's interesting is in the late 1800s, there was a group of physicians and an entire society that was really dedicated to advancing the treatment of substance use disorders. And this was the original name, and here's a little bit of a clipping. And this is an excerpt from a publication that said, at that time, that substance use disorder treatment will soon be rated amongst the most important specialties in the medical profession. And this organization really instilled some pillars of trying to understand what caused people to have issues with drugs and alcohol. And it was really anchored in what we have found ourselves trying to emphasize in the past couple of decades, in that it is a chronic condition. It is a medical condition. It is a disease that really deserves attention in the same way that other medical illnesses, chronic conditions deserve attention. So you can see here in some of the language that it's a disease, curable in the same sense of other diseases. The genetic component was highlighted. And so this energy and perspective around substance use disorders happened in our past. This is not the first time, but then something happened. And I want to show you this other excerpt that shows how clergy at the time and society really drifted away from this idea that substance use disorders were chronic conditions and deserved attention from the medical and healthcare community. And let me just say, just real quickly, before I go on, is that this also, what this society also meant to do was to acknowledge that there was some kind of like quack treatments going on for addiction, and it wanted to instill a rigorous sort of scientific community that really held treatment to certain standards and also made sure that people had appropriate qualifications. So anyway, so let me read this excerpt, which kind of depicts what happened. So we do not either in name or management recognize drunkenness in the effect of a disease, but regard it rather as a habit, sin, and a crime. We do not speak of cases being cured as in a hospital, but reformed. And the clergy at this time really saw this disease classification as medicalization of sin and an invitation for medically excusing moral transgressions. So what essentially followed after this is just a series of policies that really drifted away from what the medical community had hoped for substance use disorders and alcohol use disorders. In the notes section of this slide, I go into more detail about all of these different acts. I will leave that as reading material for you. But essentially, just to kind of sum it up, is that these policies essentially delegitimize substance use disorders as chronic medical conditions. They work to reduce access to treatment. They enhanced laws and law enforcement that disproportionately targeted racial minorities, especially African Americans and Latinx communities, and those living in poverty. So All right, so early 1900s, again, less and less in terms of a disease. Really, the perspective was this is a defect of character and morality, and the society really shunned and shamed people. And it really shifted money and attention from social services to legal, restraint, punishments, sequestration. By the mid-1920s, most institutions that were really specialized in addiction care closed, and essentially by the 1920s, the treatment system had collapsed. And what this meant is, in the 1930s, hospitals, overcrowded city hospitals and state hospitals wouldn't admit people who were struggling with addiction. They were really rejected from mainstream psychiatry and medicine. So this brings us to what we all are very familiar with. Everyone knows AA. Everyone knows Alcoholics Anonymous, 12 steps. Where this grew out of, and I'm gonna talk a little bit about, I think some of the nuance and the sort of the pros and cons of the 12 steps. I'm going to talk about that in a minute, but I really want to emphasize that the origin of this was really grassroots. It was people who were suffering, who saw that there was a marginalization happening with people who had addiction, and really building up something for people to help, to have an answer for, to have a door to walk through. And this is really what AA, the big book, 12 Steps and 12 Traditions, grew out of. So let's take just a little bit of a sidestep, because this really permeated all of treatment. So I want to talk about the 12 steps a little bit for a moment, just to build some context. So the origins grew out of a sort of fundamental Christianity, particularly a group called the Oxford Group. And the Oxford Group really sort of saw that the world's problems could be healed through a movement of personal spiritual change. And through that, it meant relying on God. It meant relying on self-inventory, confession of one's wrongs, helping others. I'm sure a lot of you are listening to that, and it sounds like the 12 steps, right? This is what informed those 12 steps. So, I think first and foremost, I think we all need to have a really healthy respect for AA and 12 steps, in that it has provided a doorway for people to walk through. It has been, it takes 2 seconds to access a local NA or AA group. It has been there for people when there really was nowhere to turn. At the same time, it also poses some issues in terms of the limitations it has and the way that it's interpreted. Again, you've got humans interpreting humans. So, and it was essentially developed by 2 white men. And so we have to understand that the lens in which they looked at the world is very different than perhaps someone of color or a woman, or another sort of aspect of diversity. So, and I think if you also dig into some of the original sort of ideas about the function and use of AA and the 12 steps, some of those things have been kind of interpreted and taken into different directions. So you really have this approach that has been reiterated by lots of different people to varying degrees, and people have added things in, deleted things. And again, I think we just have to remember that, some of the messaging in the 12 steps can be, is not entirely inclusive to everyone. And obviously, I'm sure a lot of you too know that there's the dynamic too of the religious tone. And I think it's really important for people, when you talk about the 12 steps, you need to read the 12 steps. I think it's really, really important for people to understand what they are. And you start to see, again, for some people, this is effective. But what I advocate for in the work that I do is that it should not be the only door that someone has to walk through. It cannot be a one size fits all. And I think I think the other thing is that when you start to kind of connect the 12 steps to how we treat other chronic diseases, we start to hit some walls in trying to understand, the comparability. So I think you're going to hear me talk about this again. AA 12 steps, incredibly helpful for some people. The issue that has happened in our nation is it has become the only door in which we have for people. And that poses some serious issues, particularly along the lines of medication treatment, which I'll go into in just a second. So essentially, AA spread across Minnesota in the 1940s, and what came out of Minnesota was basically what every other drug treatment facility kind of anchored its approach to. So the Minnesota model of chemical dependency treatment is really touted that AA was the cornerstone of treatment, and that the most effective approach was doing step work and combining confrontation approaches, support, lectures, one-to-one counseling, and a learning environment around substance use disorder. So it really, I think the issue is really because the substance use disorder treatment field really grew away from psychiatry, psychology, medicine. The Minnesota model essentially kind of dominated the treatment field, and it was really seen as the gold standard. And as we all have these memories of movies, it really, painted one picture of what treatment looks like. And what we've learned over the years is that a one-size-fits-all approach is not evidence-based. Treatment is very flexible, and everyone has their own needs, and it really needs to be individualized for the person. And I think the tough thing here too is AA really focuses on abstinence is the gold standard, right? That is what you aspire to. And in some places, it really even meant not even having, any substance, such as like an antidepressant medication for people whose addiction and substance use disorder grew out of potentially an underlying mood disorder or an anxiety disorder. So like I said before, I think the other thing I really want to highlight here is that accessing AA and NA, oh my gosh, there we go. There are so many, they're everywhere. They're free. There's literally no barrier to walking into a group. And that's why it's been this viable source of treatment. But when you think about what it takes for someone to access treatment through specialty substance use centers or medical settings, it is a labyrinth. It is a maze. Not only is it just from a clinical logistics standpoint within the clinic potentially, transportation, insurance, it's just incredibly complicated. And so you understand too why, why it's just really difficult for people to access care. And so this is what we're trying to change, is we're trying to move the system to more low threshold treatment and to reduce the barriers that allow people to get get access to a variety of different treatment approaches for their use disorder. The other thing that I think is important to remember too is that confrontation was a cornerstone in the 50s, 60s, 70s, 80s around treatment. So psychology and counseling approaches, behavioral health treatment, would use a kind of therapeutic approach that was really hurtful and harmful, and honestly is actually still used today, particularly in the prison systems. But it just had a completely kind of backwards way of thinking about helping people. And so here's again some excerpts of what the literature said at that time. Is that addiction is rooted in an immature defensive character encased within an armor-plated defense structure. And it was, up through DSM-2, the drug and alcohol use disorders were classified as personality disorders. And so the treatment was really, if you look at the last line here, verbal confrontation is the most effective means of engaging and changing addiction behavior. And so what this has led to is something that's even described as treatment trauma. So the reason why this is important is because you have a treatment system that used very harsh confrontative approaches. And you think about patients who you've seen who might communicate that they're not really sure if they want to go back to treatment. It didn't really work for them. I think that every single patient you encounter should be screened for if they've been in treatment and they're on the fence about going back into seeing a counselor or engaging in any sort of behavioral health treatment. I think it's really important to ask what their past experiences are. Did they encounter anything that felt like it was demeaning or confrontative or unhelpful or hurtful? So coming back to this idea that the substance use disorder treatment field really grew away from the medical field and psychology, and that has had a lot of consequences that we're now sort of dealing with and trying to address. So again, it meant that there's been a lack of training and education and exposure. Like I said, I didn't really get it until I was on fellowship. It's led to just out of sight, out of mind, and not my responsibility, and this tendency to refer out. And ultimately, substance use disorder treatments have not been held to the same standards of evidence-based treatment that we see in psychiatry, psychology, and medicine today. So the next thing that I want to do is I want to walk you through a report that was done in 2012. So I will say that there are a handful of things in this report that are changing and evolving. However, not all of these things have been addressed to this day. So I think it's really relevant and really kind of paints this picture of what the treatment system looks like, which kind of brings to light everything that I just said about the history. So this was basically a call to action. It was 5 years of research that really went into the nooks and crannies of substance use disorder treatment in America. And the results were really alarming. So, and it says here, America's approach to addiction treatment today is similar to the state of medicine in the early 1900s. It really, shined a light on the fact that people in need of treatment do not receive anything that approximates evidence-based care. Highlighted the fact that substance use disorder treatment is really separated from the medical system, and there's been a lot of repercussions because of that. And it really exposed the lack of training in substance use disorders across healthcare disciplines. So one important disclaimer that I want to make, because I am going to fly through just a part of this report, I'm just going to touch on 3 different aspects of it. And I do want to be clear that I am going to take a critical lens, but I want to also, communicate this with a backdrop of this treatment system has been underfunded, has not had a lot of resources. And as you're going to learn in a minute here, it has used a lot of assistance from people who have themselves recovered from a substance use disorder, go on to become substance use disorder treatment counselors. And like I said, I'm going to take a little bit of a critical lens to this, but I really want to reinforce that I think that is incredibly valuable and important. The issue that we're talking about here is that it is the only door. It is the only way that things have been done. Things have not been evolving and expanding and incorporating the science, and that's really the issue. So, all right, so let's run through some of these concerning and really kind of disheartening results from this study that help us understand the current state of the treatment system and why we really need medical education and medical providers and medical settings like primary care to really embrace and incorporate substance use disorder training and treatment. So a couple of different things. I'm going to go through an education and training gap, an accountability gap, and then lastly, an evidence-based care gap. So here we go. So the report basically found that the field is mostly comprised of addiction counselors that hold a bachelor's degree with some or no post-high school education. Many states require only a high school diploma to be a certified drug and alcohol counselor. And a lot of that training really focuses solely on the 12-step model. It described it as really being like an apprenticeship model, which has not been completely regulated, which means that it does not promote refreshing and accountability to advances in science. Personal experience with addiction has really been the primary qualification necessary to become an addiction counselor. And again, I think this is where it becomes tricky, because if the 12 steps worked for you, and in the field of mental health, we receive a ton of training in being able to differentiate if we think something is going to be helpful for someone versus they're not really sure if it's going to be helpful, or the idea that it might not actually be helpful for them. And so, I think there are some challenges in the system when people do not feel that AA is helpful, or the 12 steps is helpful for them. The blame has really been put on the person, not on the fact that it's a one-size-fits-all approach, and it might not be the approach that helps that person. So most addiction counselors are not trained with with the training or the credentials to also co-treat the medical or mental health conditions that coincide with substance use. This is a graph that just depicts the states that require varying levels of certification. So you can see the first line at the top, there is no requirement to be licensed or certified other than having a certain number of hours of training, and that is 14 states. No degree requirement, so associates, bachelors, that kind of thing, 6 states. High school diploma, so 14 states require at least a high school diploma, and you can see so on. So, all right, accountability. So this is another gap that was identified. So this is really about addiction treatment programs are somewhat accountable to state licensing requirements, but they're different than the same sort of institutions that are required to regulate healthcare in the rest of healthcare. Regulations really vary across state to state, with some addiction treatment programs that are state funded and religious programs are exempt from those regulations, which is a big problem. Staffing requirements don't consistently mandate the involvement of professionals who are capable of providing full range therapy. So this is, for example, there aren't physicians embedded in these treatment centers who can prescribe medications for the spectrum of substance use disorders, or licensed mental health providers that can provide concurrent evidence-based treatment for mental health concerns and substance use behaviors. Services are rarely required to reflect best practices. Seldomly are people held to needing to report outcome data, nor is that required to be made available to public. Despite this is just something that really upsets me. So despite evidence that addiction and mental health conditions co-occur at high rates and are best managed integrated, some states have treatment facilities that cannot even be duly licensed to provide both mental health and addiction treatment services. So next is, I want to point out some of the evidence practice gap. So this included a lot of survey data. Addiction treatment providers generally have negative attitudes towards medications. Some see the use of medications as incompatible with abstinence-based approaches. Again, a strong predictor of underutilizing medications, correlated with strong affinity to 12-step ideology. Studies also showed that subtherapeutic methadone doses correlated with a director with a strong 12-step ideology. Treatment providers were more likely to say that recreational therapy and leisure skills was very important versus low or rating at a lower degree things like pharmaceutical treatments. And then lastly here, 86% of the addiction counselors reported not being aware of the effectiveness of buprenorphine for opioid use disorder. I think this is a pretty powerful quote from this review, which is, there is no other comparable example in medicine where you have evidence-based treatments that are not available. So last slide here, I think, essentially, and I think it comes down to how we want to define treatment and evidence-based treatment. But formal treatment is oftentimes conflated with support services, such as mutual self-help programs. Few would really argue that any other disease be treated solely by support groups composed of those themselves who have the condition. Again, it's not that this isn't important. It's not that this isn't a powerful part of someone's recovery. It's that it can't be the only thing. Lack of tailoring of treatment services. This is really a huge finding and a problem. And this is part of why the most recent DSM shifted to use disorder, substance use disorder. It occurs on a complex, varied spectrum. Everyone is different. And opioid use disorder impacts everyone in a different way. And treatment really needs to be tailored to that. And again, most treatment follows a one-size-fits-all approach. Co-occurring mental health conditions are not adequately addressed in these settings. There's really a lack of tailoring to patient context and characteristics. Everyone's lumped to the same group. Over-reliance on group-based counseling, which is an issue. I mean, with opioid use disorder, I have really not met a person with opioid use disorder that didn't have some variation on like a subclinical or clinical anxiety disorder. Those groups are incredibly hard to be in and sit in. And some people really benefit more from one-on-one treatment. going through a rigid time-limited program assumes uniformity in disease symptoms and severity. And what this does is it overburdens people with unnecessary interventions. They go through things that they've already done, and maybe they want to, access a different approach, but they kind of need to do what the program tells them to do. And I think the treatment system as a whole, and this comes back to the chronic disease model and also why primary care is really well suited to address this for patients. But the system has really been acute care focused. So standard of treatment is a non-intensive outpatient treatment, often without adequate professional follow-up care. Once you're done or completed the program, you basically follow up with 12-step groups. And residential treatment is typically limited to 28 days, and there's little evidence that that condition remits, especially opioid use disorder, during that amount of time. So, all right, and I'm almost on time. That's awesome. All right, just kind of, what does this mean? What does this information mean about the direction of healthcare delivery and training? And I think I've kind of answered this throughout my time here and interspersed this, but it's really about making substance use disorder treatment, knowledge, and ability to talk with these patients and care for these patients a core competency in our training. If you are in the healthcare field, this really needs to be a core competency, and we really need to broaden the lens in how we think about where patients are treated, who can provide addiction treatment services. So, all right. Oh, I think that is that. So that is part one. I'm only 4 minutes over. It's impressive for me. So I'm gonna pass the torch to Steve. I'll let you bring up your slides.
Sure thing.
First, can I just say, should we pause here? I mean, that was a lot of really good in-depth information. And I wonder, should we take a few minutes to reflect and solicit questions or comments?
Yeah, that's great.
I would just offer in my experience with patients, I agree with Amber. It's very important to ask about their history and of experiences with treatment, because you will find a lot of patients who have heard in other places or with counselors have had a lot of conflict in the relationship, or may have heard from other treatment places that medications aren't appropriate or there's no use for medication, and they come in already hesitating to hear their options for treatment. So it's really important to hear what they've heard and what their interpretation of what they heard was, to be able to address some of those underlying concerns that the patients themselves may have before you can start treatment.
It's one of the challenges of moving this into a Zoom format. It can be a little bit trickier to solicit the questions and comments. And so if anyone has something now or later, raise your hand virtually or put something in the chat.
And we do have, I think we put 15 minutes at the tail end. So if there's something that,
okay,
write a question down, and we've got the last 15 minutes of today to go through any questions. No.
Great.
Well, thank you. And yeah, I used to teach middle and high school, so I will be disappointed if people don't interrupt and ask questions, or ask to go to the bathroom, or throw their gum away, or whatever they would do. So I look forward to that, and please put things in the chat, but also feel free to just raise your voice. I think this is where we all benefit from learning with each other. So I'm just sort of a little stunned each time I hear Amber describe how troglodyte-like our system of care is. It's humbling. We have artificial hearts and electrostimulators for the brain, and incredible surgeries. We can separate conjoined twins. But Jesus, we're not able to actually take care of people who have life-threatening illness, and it's virtually all based on stigma. So, I'll share my screen here, and I actually, I sort of want to deliberately pick up off of where Amber left off. So again, I can't see you all. I feel badly, but I can't read social cues. But you know, if everyone goes horizontal, please let me know so I can intervene. Well, I think this is such a key point, because it's not just that Americans feel more negative toward people with drug addiction, and here the comparison is those with mental illness. While both are treatable conditions, this is from 2014, and the data have not changed much in the last 6 years. Drug addiction seen as a, quote, moral failing, which sounds a lot like Dr. Hewitt's discussion, Dr. Cahill's discussion of, you know, what we've been looking at for the past century or more. I just want to talk about what people wouldn't want. So in this survey, people didn't want to work with people who had a substance use disorder, didn't want them having their kids in the same classroom, didn't want them to be a neighbor. So very palpable things that people were averse to in this area. And this is just despite the fact that, or because of the fact that so much destruction is caused in people's lives by substances that are addictive, whether it's opioids or alcohol. Alcohol now the third leading cause of preventable death after cigarettes and sedentary lifestyle. Just as folks have alluded to, just so much little appreciation for how prevalent this is. But I wanted to sort of bring in a salient sort of how common things are. And this is my grandmother's writing, actually. She had beautiful handwriting. I wish I could write like this. So what she writes is that she had a tea set. This is what's left of a tea set after Laura Gardner Schramm, the mother of Harriet Schramm Perot. And the story goes that the tray and large pot that were pawned by her uncle to buy alcoholic underlined beverages. So, you know, not too many steps removed from Steve Martin's life is, you know, a family that was pretty well affected by alcohol use disorder. And this is a little closer to home. This is my grandfather, who was a pipe coverer, union member in Pittsburgh, who was thought to have had asbestosis from his work, but he also did smoke 2 to 3 packs of Parliaments a day, and his autopsy revealed inoperable carcinoma of the lung and not asbestosis. So, so my grandfather died when I was 17, and a lot of his life was cut short by tobacco use, which is an addiction, and the average person with a mental illness, their life expectancy is about 25 years less than the American average, and most of that is actually due to tobacco use. So these are very prevalent conditions, and ones that we don't know, we haven't done a great job dealing with, except I'd say our public health efforts in cigarette use have been remarkable and remarkably successful. Now we have this kind of epidemic in the midst of a pandemic. And the major concern, one of the major concerns has been that people who are seeking care will not be able to find it because primary care is closed to new patients, because substance use sites have COVID restrictions, because people's transportation is affected by the pandemic. And so we are already seeing signs of not only increased overdoses in ERs, but overdose deaths in different regions. And this is a part of the campaign for National Overdose Awareness Day, which is first day of September, last day of August. And just the sentiment here that whether we're in the ER or in the clinic setting, or talking with a neighbor, or working with our own brother, like this, people are related to, people have an interest in getting better, that we can make a direct contact with and have a direct impact, as we heard in Jenny and Joe's stories. Just a quick sense of like what's not effective. What's not effective is doing nothing. So here's this graph was a remarkable study looking at 40 years. It's very hard to do these studies at a set of people who were who began opioid use in 1956 and were put in a federal center and then followed after their discharge. And just most everybody ends up dead. That's about 48% of people. Some people in that time were on methadone, 2%. Some were still using, and 4% were incarcerated. So this actually should be recapitulated now, as we heard Jenny describe, out of a small high school class to have a mortality level that's almost 10% at a young age is almost unprecedented in U.S. history. But we have had precedents where we felt hopeless before, and where we've had stigma play an unbearable role in people's experience of illness. And during my lifetime, that's certainly been HIV/AIDS, starting in approximately 1983. I remember learning about gay man's immunodeficiency disease in high school in biology, and here we have people literally wasting in cachectic and having nowhere to go. Many of them, thankfully, being taken care of by their families. This is 1990. 1990, we really didn't have triple therapy until 1993, 94. It's wrenching, and yet people can now have a normal lifespan with HIV/AIDS. So I think making that kind of change that Joe and Jenny both described, like this is not a 10-degree change in someone's life. This is like close to 179 degrees for some people. It's pretty marked. It really gives you hope. This is actually a set of photographs from Haiti, from Paul Farmer's group, doing work there and showing the benefit of treatment with antiretrovirals for HIV/AIDS. So people do not have this kind of physical change before us when it comes to opioid use disorder usually, but the functional changes, that just changes in someone's spirit, are as dramatic, if not seen visually. Any thoughts at this point? I'm gonna stop sharing. I don't like this idea of stop sharing, like I don't want to share anymore. I'm not a sharing person. I am still sharing, but in a different way. Has anyone had any insights either in their work or with family or people that you care about where they haven't been able to, they've not been served well by current society or current healthcare in the US?
I don't think so. In my past, I haven't come across that as of yet.
Yeah, that's great to hear, Michael. Yeah, I hope hope that continues to be your experience. That's good news.
I mean, I try to get my clients to go to AA, but some just don't seem to want to do that. I'm using, mindful exercises to help them try to focus on themselves. Mm-hmm. And art, I like to bring art into everything.
Oh, good. Good. You should meet someone that I've just met today. Her name is Jane, and she would like to work with you, like and Elizabeth in that work. So So that's powerful, and I'm grateful to hear that people are finding what they need in your experience.
So I've had the experience somewhat commonly, and I think this kind of follows nicely with something that Dr. O'Reilly said earlier, where we'll have patients who are coming in who have struggled for some amount of time with opioid use disorder, and they start on buprenorphine or Suboxone, and they have the idea, driven from the patient really early on, that this should be as short as possible. So, starting on the medication, making noticeable improvements, and within a matter of weeks coming in, pushing really hard to want to try to get off of this medication. And I guess the challenge that I experience as a clinical psychologist who is interested in evidence-based treatment, a patient-centered approach, and specifically a motivational interviewing tactic, is trying to balance a desire that often seems to be coming from a really good place. I want to do a good job. I want to be healthy. I want to be proud. And I think that means not being on buprenorphine ideally at all, but certainly not for a long period of time. And so trying to find a way to, one, sort of separate how much of this is truly a patient's desire based on his or her experience versus them coming at a perspective, kind of repeating from what they have heard, a message coming from the perspective that Amber kind of articulated earlier. And I guess some of the some answer I have, in some ways, that often strikes me as a time that it's difficult for patients to kind of give informed consent in that situation if the information that they are operating off is perhaps outdated or inaccurate, and just sort of struggling to try to figure out what is the appropriate amount of lean to put on a patient to even get them to reconsider that information, particularly if it is coming from sort of a well-meaning and loving family member. So that's one thing that comes to mind for me.
And that's very helpful and very present in current care. Hey, Jenny.
Oh, yes, Steve, just generically, my own experiences with family, I've seen a lot of failures in the medical system, but just in my own experience as a provider too, I think we start with a patient with expectations a lot of people can't meet. You need to get here. You have to see me in person for an appointment. So figure out how you're going to get here and be here on time. You're going to have to pay for the visit. And if you don't have insurance, then you're going to need to pay out of pocket. I'm going to give you this prescription and you need to figure out how to get somewhere to get it. You need to be able to pay for it if you don't have insurance. And if you do, you need to be able to navigate the insurance world to get that prescription. And then you have to understand everything I said in a 10 or 15 minute visit about how to take the medicine and what the side effects are, and come back again and do this all over again in a month or two to follow up. And those expectations and the way we've designed our healthcare system are hard if you work in medicine and you have a family member. My father had cancer and had many treatments across many different health systems, and to try to coordinate and get records certain places and to transport him to all these visits and keep track of them, it was extremely daunting as a physician who has a decent income and a car and the ability to get places and paid sick leave, so I can take time off for these appointments. And I would say with any of our patients, especially our addiction patients, the failure I see again and again is that because of our schedule and our time crunches and everything else, if you can't do all of those things as a patient, I can't treat you. Show up or you don't get the medicine, or pay for your medication or you don't get the medicine. Or a lot, what I see in this area is you can't get your treatment at a primary care office. So you're going to need to go to a clinic who did decide to do this work, but is going to charge you cash only to get your prescription, because this is separate than, and you're asking them to do something extra special by treating your addiction rather than treating it as part of your chronic medical illness. So you're going to have to pay more money for that. And I think that failure to see every part of the human condition as important and worthy of treatment in our medical offices is one of the ways, again and again, that we fail patients, and also just the lack of social supports that most people need to navigate our system is one of the things that we see again and again.
Yeah, I'm glad we're recording this because I'm going to play your account there, Jenny, to, it's like a bedtime story. That's a sad bedtime story. Because I think in healthcare, our fetish is to make processes work well by our accounts of what work well is, and not keep our eyes on the prize of what's going to actually work well for someone's life. And the net that you described there of falling dominoes that just sort of can't come together is humbling. And I don't know. I mean, in this work, it's just people do have some of the most heroic lives I can imagine. Some of our patients, all of our patients, actually. I do far more heroic work than I do as a heroic healthcare worker, just by virtue of the fact that they're making it through their lives each day and waking up the next day and getting up and doing it again with as little support as they may have. So appreciate calling attention to that. Any other thoughts before we?
One of my.
Oh yeah, Jane, please, yeah.
I experienced 14 years old. My best friend overdosed. We did not know he was partaking. His parents didn't know. So that was my first very young age of experiencing anything with drugs. And then my mom's brother died suddenly. He was an alcoholic. And so it's really touched very closely to our home life. And being a small business owner, I wanted to do more for this community who is dealing with substance abuse and wanting them to know that there is a place for them and they can be successful. Some of the stigmas that I heard through family members not understanding or our society, if they choose to use medication to help them with their substance abuse, is that full recovery. And, and I want to get away from that stigma. I want people who don't have the education and understanding of addiction to not put that out there, because I believe there's many ways of treating. I also believe in the arts wholeheartedly. That's our business. And I believe you can express yourself and your demons or whatever you want to call them. I don't even like to use the word demons, but those addictions you can express through art. And there's jobs out there, because there's also the stigma, oh, you can't make money at art. And I can prove to you differently. I have a business in art. So, I definitely want to really reach out, and that's my goal, to get this non-for-profit up and running, but I have to get educated first, because I do not want to bring stigmas into my dream of for others. So this has been very helpful, but I would like to know where, I don't understand the stigma. If you're using a prescription drug to help come over addiction, where is that coming from and why?
Right. I think, gosh, you that's worthy of like a play that someone could write, right? I mean, it is very much of a sort of a Calvinist approach to the world of you should be working harder and stronger, and this is a moral question rather than a disease or condition question. And we don't ask the same, Elizabeth, as you sort of alluded to, but we do not ask this of people who are going through a certain amount of chemotherapy for cancer. We do not ask this of people who are septic and need a certain amount of IV antibiotics. We don't say, just try harder and maybe you don't need drugs. So I think what's become too convenient is this idea of substituting one drug for another. And as our colleague Dan Mullen, also from Barry, says, okay, if we use that model, it's one drug that won't kill you and one that will. So we think that's a pretty good trade. So I think we do have to find lots of ways. I think what art provides also is metaphor. I think we need ways of comparing this for people so that they're forced to leave their current, or at least question their current way of thinking. And metaphor and arts are really powerful for doing that. So I'm really grateful for that. That's the kind of work that you're going to be doing and are doing. So, but I do want to say that just as it is in the case of unconscious bias and racism, I think ridding each of us, I'll speak for myself, ridding myself of all stigma is not like I have a hard time like getting to zero, and it's not something that I want to at all clinically affect things, and it's something I want to be very aware of. But you know, there have been times where I'm like, why are you lying to me again? I don't really use that. I mean, why are you just not being upfront with me? Why, you know, in the back of my mind. And then what really saves me for myself is this is not about me. It's not about me. And then once I can get into that space, it really opens up the human relationship again. And it's just making it transient and then really finding a way out, right? It's not about me. And I think just being cautious about judgments that aren't useful is really key to the work. Because people have survived because they've sort of seen the truth in the way that they want to see it or represent it. And so it's been a skill. And as Jenny mentioned with other cases or other treatment settings, like trust is tough. I would have a hard time trusting the system. So people don't know how hard the outcomes will be or how high stakes you'll be if they say the wrong thing or do the wrong thing.
So I guess, I don't know if this really clarifies or not, but just sort of another layer to the discussion. I mean, I've tried to drill down on this before with some patients when they have this idea that somehow avoiding heroin while you are using Suboxone is somehow not as good as avoiding heroin and not using any sort of a medication. And if you do this sort of the downward arrow and drill, it seems like underneath that is the idea that it's somehow not fully me who is doing it if there is a medication on board, that it is the medication who is doing it rather than me. And I think that if you drill down from that, it's sort of an idea of what is the essence of self. I mean, is self sort of a series of behavior and consequences driven by environment, or is self something different? Is self a soul? And I think that for some folks, if you really, really drill down to it, that's part of it. That it doesn't count quite as much if you are doing it only because of some sort of an external medication.
That's so salient. And I think one of the cool things that you're doing, the folks who are with us around our figurative Zoom table, but what you're doing isn't just working with individuals as you will be and are. Once people have the proof around them that people they care about and respect are getting better, and one part of their getting better is using buprenorphine, that will speak more volumes than I can speak. But that you need a critical mass to do that. And to get a critical mass, you got to start with the first step. But we don't, that's a cultural change that's going to come from the work that you do, is the kind of face validity that people will have when they see people getting better. There's really, it's very powerful for people to come in and say, my friend Steve has been on Suboxone for a while. I see that he's getting better. Maybe I should think about that too. So one of the things that clinicians or people in healthcare sometimes say is that it's too hard to diagnose this, or it's too complicated. And so I just want to run through what constitutes an opioid use disorder. And just to, as you look here, there are 11 elements in a formal definition. The last two are not allowed to be used if someone's prescribed an opioid medication and they're using it as prescribed. So someone prescribes me an opioid over 4 or 5 weeks, I will develop tolerance and withdrawal, even though I do not have an addiction. And so really unpacking, separating these words of addiction, which is a compulsion and a craving to continue to use something despite negative consequences, versus dependence, which is, I usually use this medication, and when I don't use it, like an antidepressant, when I stop it, I have side effects from stopping it. And as a withdrawal syndrome, or tolerance, that I might need a higher dose of blood pressure medication over time, for example. So, but the other ones are actually pretty not so hard to sort of put in place. And this is a nice little vignette, not so nice in some ways, but it helps understand in these 4 paragraphs, a patient with a back injury who's been escalating his oxycodone use. I think I actually made this gender neutral, so now I've just given it away. But it is intended to be anybody. The adult children are worried. The person's had some overdoses. Oh, she suspects. How about this? And she suspects that she may have had fentanyl instead of heroin. This is almost not needed anymore because virtually everything is fentanyl. And that detox hasn't helped, and this has led to incarceration in the past. And so if you actually just listen to this short story that a patient's telling you, she's telling you every one of these in this one vignette. So there are certain cases where it's sometimes tricky to figure out whether someone has a dependence and some aberrant behaviors, or whether they have more of a substance use disorder. And those are interesting questions, but by and large, this is not going to be a subtle diagnosis. So I just want to shift to sort of the key aspect here, which is if we don't know what our goals are, then we get trapped by the kinds of things that Jenny described in terms of barriers to care. So if the goal of care is, let's say, not just for opioid use disorder, but for all primary care, I think we have 3 goals. 1, make it easy for people to start their care. Because if nobody gets started, nobody gets beyond the start, right? If this part does not happen well, then the rest of the work that we do really isn't that useful. We also want to make it hard for people to leave care, not in a punitive way, but sort of if we think there's something beneficent about the work that we're doing, then we want to put energy into it so that people don't get, quote, lost to follow-up. Because loss to follow-up in this line of work is a red flag and concerning. Like something's not going well for someone most times when we don't know where they are or how to reach them. And lastly, I want to put something that we don't often talk about, but which I think is the most salient, which is what are the patient's goals? Because once we start to conflate our goals and the patient's goals inaccurately, we end up with a situation that doesn't work for the person we're taking care of. If my goal is to get a blood pressure of 138 over 72, and the patient's goal is to get it to be 192 over 97, then their goal wins. So I can talk about why I think my goal is a better goal and lend credibility to that in some way, but ultimately, let's please have goals that align with what our patients are looking to do. In terms of getting started in care, this is a gentleman in Brooklyn with COVID-19 who started care for his COVID-19 when 3 EMS workers showed up and immediately provided respiratory support. So getting started there in care wasn't so hard. This woman started in care for opioid use disorder when she overdosed on a Boston sidewalk and was cared for by people fairly immediately. But so we've gotten better at helping with these acute situations for people. In an ER setting, we've gotten a bit better. In EMS and our frontline colleagues have gotten better in many communities in terms of use of Narcan and saving lives. And so that now falls on us to take advantage of the fact that people survive their acute life-threatening moments to now live their lives with us in primary care. And this is a story, this is just from late last year, December 31st. One of those, supposed to be funny articles in the New York Post of a woman in Kentucky who used her dog's urine for her probation visit. She, quote, said she admitted to using methamphetamine and the painkiller, in this case, Suboxone, and she faced charges for trafficking in a controlled substance and tampering with physical evidence. Now, that's an interesting point of view for her. That's sort of a carceral point of view for what someone, this woman is doing, but really, she has an illness and she needs medical care. So we're using the wrong frame for her. And if we had a picture of my grandfather cachectic with lung cancer and a similar story in the New York Post, I'll tell you that would not fly very far. So it is shameful that this is seen in the kind of light that it's represented here. And it's a continuing tragedy. So I spoke earlier about metaphors. One metaphor that has some utility, I think, is comparing the disease of opioid use disorder to other ones that we take care of in primary care. So we take care of quite a bit of diabetes in primary care. Diabetes is at epidemic levels, you could argue, in the US and other developed countries, and it benefits from a clinical relationship, but we don't have highly effective treatment for diabetes. And don't let the drug companies tell you otherwise. And it doesn't tend to be abruptly lethal. And it's also less stigmatized than it was, let's say, 20 or 25 years ago. We take care of ventricular arrhythmias. So this is a lethal arrhythmia, lethal rhythm disturbance of the heart. We take care of those. They tend to happen very quickly. And this is sort of the athlete falling on the floor during a game. We have a highly effective treatment with automated external defibrillators, and we deploy it. We take care of HIV/AIDS, which meets almost all of these criteria, except it doesn't tend to be abruptly lethal. We take care of cancer, which can have highly effective treatments for certain kinds and for others, unfortunately not. And cancer itself used to be highly stigmatized. In fact, the place where Memorial Sloan Kettering is in New York used to be a cancer, quote, hospital. If you had cancer in the 1920s, you were discharged from a hospital and sent to a special hospital, essentially to die. And the hospitals were evaluated by their death rates. And so they discharged people who were dying of cancer. So every disease, many diseases that we think of now as being relatively, assumed by medical culture, have had their own stigmatization. And here we have opioid use disorder, which I'd argue hits all these buttons, except it's not really medically complex. It's like medication's helpful for just about everybody. And then you have to combine it with behavioral and supportive and caring work. So, and as James alluded to, you can't stop it too quickly. So if you stop it too quickly, there are effects of overdose and death. In Britain, the study showed that you needed at least a year of treatment to start to reach the same life expectancy as your age cohort. So I think that that's a reasonable number. That's probably the hardest data we have. And then people also had, as Jenny pointed out here, hassles. Like, these are the reasons people stopped. Why would you stop? You have hassles. You have a history of emotional abuse, lower levels of a positive mood. Like, these are things that we can be tuned into in primary care and help alleviate. I want to show an example here from the University of Washington. In this study of people who are very good at their work, this is a very well-run clinic. They did this study out of an effort to improve their work. Out of 100 people who called, 40 people were actually started on medication, which, seen in other ways, a failure rate of 60%. If we had surgeries with a failure rate of 60%, like that person's not operating anymore. And I really appreciate them sharing this data, because what they did was they unpacked all of the obstacles someone would face. They needed a complete intake, and then a nurse visit, and then another doctor visit, and then to come back again. And you could just see how the filtering process gets underway for patients, because it's something we determine is necessary when it's not. Similarly here, this is a study out of, actually this is a set of studies showing that over a quarter of people discontinued buprenorphine in their first month. This is highly related to a low dose, 4 milligrams or less. And interestingly and importantly, psychiatric comorbidity was not a significant variable. So people of all kinds can continue this. But this thing is not great. Like this yellow line, this orange line going from here to here, this horizontal line is a problem. It means like all these people dropped out of care that early. This is time zero. This is 180 days, as James alluded to earlier, right? And look how many people are making it to 180 days. You know, Bassett there with your 85% strength, 25% here. And if they started with a low dose, let's say 15 if you're lucky. Just grim numbers for a life-saving treatment. This is represented also in Rhode Island, where they're actually able to get state-level data. And out of about 50,000 people in their population who have OUD, only roughly half have been diagnosed. And of those, only about half have initiated treatment. And of those, maybe 3/4 have stayed in treatment. And then the last one, I asked the authors how they came up with this, and they said, well, we just sort of cut the number in half. So you have 9% of people staying and identifying that they're in recovery. That's very hard data to get. So these are not great data, and Amber alluded to these with her earlier work, but this is from this year. It's not like someone's figured out the secret sauce except for Bassett. So we've got to get better somehow. So I think one of the ways we get better is we think about what are the goals we really want. So what we want are things that matter to people. And we want to ask people what matters to them. So a couple of the things that matter most to people I've taken care of: getting their license back and getting a car. Having their Department of Children and Family case closed. In getting a job and reuniting amicably with friends and family that they love. Like those are really some of the top 4 or 5 things. Instead, the literature really focuses on negative urine drug screens and treatment retention as sort of a proxy. So you're going to hear Amber and myself and everybody else on this call maybe use this term low threshold care, which is the care that any one of us would want. When I pick up a phone with Dana-Farber for Cancer Center, I pick up the phone, I get an appointment for tomorrow with a specialist in the type of cancer that I or a relative have. That's low threshold care. They get the slides from pathology from the other hospital. They do everything else. That is low threshold care. That's a model for us. If we're not making it that easy, or as easy as it is to get heroin, then we're not likely to meet the needs of someone who's really struggling for help. This is the best slide I've seen, the best sort of development. This is done with patients in a community health center in Philadelphia. And I have a tattoo of this on, I'm not going to tell you where, but I have a tattoo of this so I can remember it and how important it is, because it talks about what the harm reduction principles are that Amber's going to develop with us in the next section. But then what would you expect to have happen? Well, you'd expect a lower overdose rate. Well, we like that, right? That's an interesting goal. How about people are more likely to access, continue, and return to care? Also sounds like a pretty good goal to me. Like, is the goal a negative urine test? That's not on here. Is the goal complete abstinence? Also not on here. And making the perfect the enemy the good has catastrophic effects for patients. And that's what gets in the way. That's what I'm just going back to this because I must. that's where your curves will change. These are largely administrative discharges or discharges by virtue of obstacles. People don't come to buprenorphine care often like they come pretty ready to get treatment. Like they've made a serious step in their minds about what they're looking for in terms of their health. So we just have not to get in the way. And we have to support. This is another way of seeing the same thing, but it just lists, again, low threshold principles, same day treatment in the home. Reduction is fine, not abstinence. You can use other stuff because guess what? We don't have great treatments for other stuff and we're not treating you for those things. If you're getting better, we don't need to see you every hour. We encourage mutual aid meetings like AA or NA, but they're not required. And if you want to come back, we come on back. So like, this is not rocket science. Again, it's sort of, I think, public health and most importantly, clinical relationships that we, in the way that we would want to have them for any element of primary care. If someone, so anyway, I'll put a pause there. I'll put a pin in it. But I would take those last two slides and I would just sit with them and your colleagues and just sit with them. And because we have to do this intentionally. And if something's not going well, or you have a question, or you're thinking about the work you're doing, just consider, are those the goals that you're using, or are you unintentionally using a proxy goal? I don't know. I mean, like negative drug screens. Negative drug screens doesn't mean people are getting better. It just means that the drug screens may or may not be negative. So I'm bringing us to the top of the hour, but I appreciate any impressions people have.
So Steve, just a quick comment on those veins. I would say every patient with addiction that comes into your office doesn't need a conversation about the negatives. Everyone in their life has already pointed out all the negatives that they are experiencing or maybe causing or contributing to. That is what they hear all day, every day. And so we start every visit with a what's gone well. Since you were last here, I want to hear that first. And then also if what's happened since the last visit is I used heroin twice and they started our program using heroin 6 times a day, then we'll talk about how impressive of a change that is and congratulate them for being able to make it that far and what a huge accomplishment that is compared to where they were and where they are now. And everything needs to be reframed as this is an improvement. You are doing wonderful things and this is really hard to do, and not why did you use it twice? Because they're already asking themselves that. They're already beating themselves up over it if they are trying to quit entirely. And that's not the feedback that they need. They need constantly to point out the successes really helps more than anything because they're already beating themselves up. Whatever has happened between the last visit and now, most of them are already focused on the negative because that's what they're used to hearing about from everyone in their lives. And our job, I think, I take my job to be their cheerleader and help them reframe and focus on the positives.
Right. I think I love that. It's I had to learn this term again from our psychologist friend, Dan Mullen, unconditional positive regard, right? Meaning basically, I think you're a good person and I'm going to approach you as though you're a good person and recognize that what you're doing is hard and it's not going to go always the way that you want or I want, but we're going to be on this road together. And for someone to have the expectation that you care about them, as Jenny described, is really, it's not on a prescription pad, but it is as important as any, or more important than any medication. You can do buprenorphine care very, very badly, super, super wicked badly. And we have, examples of that all around the country. That's not what we're here to do. I know I'm 1 minute over. I didn't quite make it like Amber, but glad for us to take a break if that's okay, James.
Yeah, I think that sounds great. I think we've got the 10-minute break built in. So let's start again 3:10 or so. Yeah, feel free to mute yourself or not. I'm happy to sit here during the break if anybody is inclined to wanna discuss. I'm happy to do that. Otherwise, we'll start again at 10 after 3.
Thanks, everyone.
All right, everybody, we're starting to come back here from break. I think Steve's gonna lead us again coming into the second half of the afternoon. Just another chance if people have questions or comments. This is a nice time to sort of put them out there and give us sort of a chance to do our best to try to address as we go forward. But I hope this is going okay for everybody so far. Steve Martin, physician version is back.
Is there any other version? There are so many, right? Yes, that's right.
Yeah. Physician and amateur comedian.
Yes, super amateur.
I was just saying to the group as we're coming back online that I think you're going to be leading things off again in the second half, and just encouraging folks, if there are questions that come up based on what we've talked about so far, we'll have room at the end, some dedicated Q&A time.
Yes.
But if I'm sorry, I'm reading a message from Michael saying that he can't hear.
Okay, can Michael hear? Can you hear Michael? Yeah.
Well,
yeah, I'm good. I got you.
Oh, good, great.
Okay, great.
Thanks.
Okay.
Yeah. Well, thank you, James. I'm back. I'm stretched out. I have less lactic acid in my body, so I feel good about that. Yes. So with this next part, if again, thoughts in chat, please speak out. Whatever hits you. In this next part here, which we've titled sort of a clinical care model, is just basically ways of operationalizing the goals that we discussed about care. So if this talk does not sort of have similar elements to it than what I just spoke about, then it's not going well. And so there will be elements of intentional redundancy, but not boredom, I hope. Very, very big difference between the two. So we have completed our journey here. This is one of my favorite slides from colleagues in Camden, in that we are going to discuss a clinical care model. It could be really clinical care models. I mean, there's no cookie cutter, so to speak, that may work, and not all clinical care models work out exactly the way you hope. So not everything that I mention here is sort of something that I've done approaching anything perfectly. And it's just good to have colleagues where you can sort of figure things out together. So first off, I think one of the many reasons why we haven't had as much uptake in buprenorphine provision in primary care is this idea that that's just too complicated. And I've been looking for data to support this sort of green square and yellow square, orange square idea. But suffice it to say that most of the patients who walk through our doors who have opioid use disorder, we can take care of well in primary care. And that's sort of this area under the curve. So that's like this big group right here. And there are some people, my wife does care with a methadone treatment center. She does care in residential treatment. So there are certainly people who will benefit from that being part of their lives, or a temporary partner of their lives, and for whom those are better. And being aware of that is really key. But no one would start a program in primary care if they thought this whole thing was orange, right? You wouldn't start things that you didn't think you'd help like 2% of people. So I just want to emphasize that even in the era of fentanyl, we have, as James showed, a really high success rate with patients, and that's possible and doable. I had the good fortune of being part of the authorship team for a paper from late 2018 that points to this idea of the virtue that you have if you're on the Zoom call. One virtue that you have is not coming to the table with a lot of bad habits, because a lot of buprenorphine programs had developed sort of 10 years or more of practices which had never really been proven to be either necessary or helpful to patients. And so I'm going to briefly walk through them, because these are areas where research has clarified a better path for the kind of care that we provide. So on top of that, there are just some general things that we've learned together. One is people get better. Each person you've heard from, Joe and Jenny and Amber and James, anyone else, people get better. The secret sauce is your relationship with the person you're caring for. This is not a transactional relationship. This is not you pay me a certain amount of money and I give you a certain amount of tablets kind of relationship. Remarkably, some people can still succeed with that kind of relationship, but it's a much smaller group. And the idea that you have a strong therapeutic relationship with someone is invaluable. In its review of urine drug testing in 2017, the American Society of Addiction Medicine's first paragraph said, "We really don't know if it's helpful." And then they wrote another 23 pages about it. But let's start with that first paragraph. We really don't know if it's helpful. We do know that it can be hurtful, because many people in primary care make errors when they interpret a test. Many people in primary care and other settings make a high stakes result for drug testing. And many patients feel the need to either adulterate or not do this testing for fear of being removed from something that they're finding very beneficial. So I would, over time, as we discuss this, but testing really has to be done judiciously. And in certain select cases, it can be quite helpful, but as in testing everyone all the time, please just recognize the fact that you're trying to protect people from harm. Individual counseling helps some patients and not others. Some of these ideas we've already thankfully touched on. People can harm reduce with their opioid use, but continue to use other substances, either because that's what their choice is, what they want to do, or because they would actually like to stop methamphetamine use. And it's really, really hard to stop. It is so hard to stop meth. And we don't have any evidence, FDA-approved treatments for methamphetamine use disorder. It's humbling, it sucks. And if you're stopping longer term meth use, you're looking at an extended period of depression as part of your getting better. So it is just like, it is not a cakewalk. And so we come back to the clinical relationship as a secret sauce, because as a substitute for interventions that are medication-based or experience-based, the experience has to be our ongoing relationship, and always trying things that may provide benefit but not harm to people. There's no reason to have any delay in starting buprenorphine. It actually, with the pandemic, you can start it over the phone. And it should be done that way. If someone called us out of the blue and said, "I'd like to get into your program, but I don't have a car until Tuesday," let's write a prescription until then. We just have to make sure the person's not allergic to buprenorphine and that they have an opioid use disorder. And then we do that to reduce the risk of someone's harm from overdose. Our Narcan works, and many of our folks are familiar with it, and some aren't. And Narcan only works if someone else knows how to use it, because you have overdosed. You will not be giving yourself Narcan. So this mandates that someone have a relationship where they trust someone enough to help save their life. So it opens up a lot of questions and solutions for people, but it is thankfully people have become much more familiar with it. Detox itself, I'm going to refer to this occasionally, as you may have heard in medical care, as quote a higher level of care. Steve, we just can't do what you need here. You need a higher level of care. And Steve, this higher level of care, you're going to have to quit your job, because you're going to have to go every day at 5 a.m. And you are going to go there and be in these groups and things like that. And you're going to be sleeping overnight, actually, right? So you have to find someone to take care of your kids for the next month or two. And, the other parts we're going to do there, we're not going to give you medication there because we think that people are just wimps if they need medication. So, and you're going to lose your tolerance to opioids, and we didn't give you medication, and we didn't plan for it when you got discharged. So now you're going to overdose the first time you use, as we would expect when you return to use after you're discharged. So,
Steve, can I pause you for just a second here? I'm getting a message from Jill that she can't hear us.
No.
Is there Jamie, I can see your face here. Can you hear us? Can you nod or raise your hand or something if you hear me right now?
One new message.
Oh.
Oh, a great message, Jamie. Yeah.
Well, she must be able to hear us.
Okay.
She's
not
answering me direct. Okay, she is nodding now. Okay. All right.
Great. Okay.
So it must just be one person.
I'll just speak really loudly, and I'm sure that will help everybody. Thank you very much. Okay. Please let us know though. Oh no, if anything we need help. Okay. People, when their housing becomes unstable, when their food becomes unstable, their income, whatever it may be, often very low, is unstable, their relationships are unstable, that is often a quote trigger for people, and they will want to escape that bad feeling just like we all do. But their defense mechanism is something that can kill them. That's the difference. So my defense mechanism is to, I don't know, go for a bike ride or read a book or work in my coloring book. I don't know, but those are defense mechanisms, but it's how you're defending your ego that's key, and not trying to hurt yourself in the process with substances that have high levels of craving and concern. And the last one is just that fentanyl is awful. In case anyone wasn't clear about that, I'm all for fentanyl for colonoscopies and surgeries and on the floor for pancreatitis. I'm not a fan. No, it's just completely awful. This is non-prescribed fentanyl. This is produced at scale in, it looks like often places in China, especially, although that route has been disrupted and with the pandemic. And so we're getting more from Mexico. It's just an awful, too easily made synthetic opioid that kills a lot of people. In Massachusetts, 97% of our opioid deaths had fentanyl. People had fentanyl in their system. So these are not like the old days where someone might overdose a bit on some OxyContin. Like those days largely are gone. It's fentanyl is really the disaster. And remarkably, buprenorphine still works, even against this very potent synthetic opioid. So just to walk through some guidance on care. Oh, good, thank you. Just thinking ahead, we've talked about this in brief, but I just want to sort of show you why things are important. So it used to be back in the day that in my health center, people would schedule a 3-day induction. 3 days. Remember these days, Jenny, James, right? These 3 days with Dr. C, right? And you'd come in one day. I don't even know what happened. I don't know what happened during those days. but something would happen each of these 3 days, and try to find 3 days in someone's schedule. Like, that's not the easiest thing to start with, and then 3 days off work and 3 days, I could go on. Don't do that. Please don't do that. 97% of people should start this at home, and probably have already started this at home. And for those few who need to do it in the office, it's often because their transition to Suboxone from wicked high extended use of fentanyl makes that transition trickier. But I'm going to start with the 97%. Most everybody does very well at home, and it removes critical barriers that people face otherwise. Another
Steve,
one, yeah, James, sorry.
Am I recalling correctly that, not that this would exclude somebody from doing it at home necessarily, but somebody transitioning from methadone to buprenorphine can also be tricky?
That can be tricky. And it will actually be something, as you build your, thanks so much, James, as you build your practices in the Catskills, one effect will likely be that people will come back home. They'll come back out of a methadone setting, and they will want to enter care with buprenorphine, which is absolutely very possible. So the dose ranges where methadone and buprenorphine are roughly equivalent is probably about 40 milligrams of methadone. So when people get to about 40 milligrams or 35 milligrams, their transition to buprenorphine is very reasonable. And I love methadone when people need it, but I've also had people who hadn't gone on vacations for 10 years because they couldn't get a partnership agreement with their methadone site, and there were no take homes of methadone. So for certain—
Absolutely. Well, and where we live here, I mean, this is true at Bassett, and I know that it's true in Delaware County as well. Just very practically speaking, when we started this work, we came up with a map and located the closest methadone centers. And from our sort of initial participants from a clinic perspective, there wasn't a single one that was less than an hour drive one way. And so, forget vacation. Think about just trying to have a normal life, have a job, when every day you're supposed to drive to a clinic to get your medication. It just practically, we talked at the beginning, I made sort of a half joke. It's not a joke, but being greedy for our patients. Yes, we want them to reduce and avoid use of heroin or fentanyl or whatever the case may be. We also want them to be able to access a meaningful life that includes work, family, and vacation. So it's a useful medication, but it's got some barriers.
It has barriers, and those barriers, thanks so much, James, are created by human beings, in case you were wondering. So human beings, in fact, American human beings, decided that this medication, methadone, needed to essentially have a gated moat around it, and that it's so lethal, we have to have all these protections, when in fact, it's actually the lack of access to methadone has killed far more people than methadone ever has. And it's criminal, the current state of affairs in terms of policy. So what's starting to happen in our area, thankfully, is that community health centers are partnering with methadone sites of care to be able to offer that to their primary care patients, and they're co-located. So we just need to change laws and change availability, because for some people this will actually be their treatment of choice, and they will try Suboxone, buprenorphine, and then they will try methadone, and they'll say, I just feel myself again on methadone. So instead of sort of forcing people to choose, really from a policy perspective and a humane perspective, we should have these be equally accessible. Another medication that people sort of shy away from are benzodiazepines, and the initial thought here was from a case study of 6 people in Paris. And these six people all injected buprenorphine and injected benzodiazepines, and they overdosed. And this was a lot of stuff, like a lot. And then so somehow this then became woven into initial guidelines for buprenorphine. And there's a study coming out of Rhode Island that the authors won't let me know the results to, but I'm inferring that the amount of benzodiazepines in overdose deaths are actually lower than they expected. currently. So all this is to say that if someone's already using buprenorphine from the street, benzodiazepines, clonazepam, Xanax, Ativan from the street, and they are seeking out buprenorphine care, there's almost no reason not to start. And there's every reason to start, as per the FDA. And if someone's prescribed benzodiazepine and is using it as prescribed, there is again no reason to not use buprenorphine. So this in 2004 was seen as sort of verboten and a relative contraindication, and now the risks of ongoing opioid use absolutely outweigh the benefit for most everybody of the combination of both. Okay, and please, again, I'm looking for chats. I'm looking for people telling me to shut up. I'm looking for things that you would want to say. Okay, here's a classic one, as was alluded to by Amber, right? You've had your 28 days, now you're all better. No, that does not happen. It never happened. It's a construct that's false. So people return to use. I should have changed this slide. I've been really, I'm an English major, but I've been very persuaded that using the word relapse only brings us right back to this idea of moral authority and a lack of will. And the word relapse in an addiction actually derives almost exactly from a religious-based approach to abstinence. So this is like a relapsing, like sin relapse. Like this is not like some sort of benign idea, but that you've sort of gone back to sin. So I like the idea personally of return to use, which is sort of a neutral term, because my patients with type 2 diabetes aren't relapsing because they had a piece of pizza. They've returned to the use of pizza, which is what human beings do. So let's get used to that and make decisions based on reality. Rhode Island, Maine, other states, close to us, thankfully not New York. New York has been really, to my mind, very ahead on policy, and for the most part. But in Rhode Island, you were required to have one-on-one counseling to get buprenorphine. Rhode Island's a fairly progressive state in terms of policy for healthcare, but not that way. And that, again, is just a barrier to people. And many people don't find counseling helpful, and some find it life-saving. So let's figure out who's who and have, reserve it and have it available for people who really like it and need it and benefit. But not have so much not dilute it with people who are not finding it helpful and instead have it as an impediment.
Let's, I mean, as the clinical psychologist here, Amber, you, I'm sure, have thoughts on this as well. I think it's also important to kind of consider what is the focus of counseling that folks are receiving if they are coming in for concurrent counseling while they're taking buprenorphine. If the counseling is continually just hammering home the sort of continued need for somebody to quit use of substance or not so subtly reprimanding them for any missteps, I guess to me that's not surprising that it would be unsuccessful. On the other hand, if the counseling is targeting something that is maybe comorbid with the drug use, but not identical, something like trauma or PTSD, that seems much more likely to me to be useful. And I'm hoping to see and perhaps even participate on some research on that coming soon.
And I think what you'll find, again, asking patients about their history of experiences, if they went to county clinics or other places looking for counseling because they had a history or active addiction, they were automatically relegated to an addiction counselor and weren't able to get access to a counselor to talk about their PTSD or their underlying mental health issues or other things they want to talk about. That's actually quite common in our area. And patients get really frustrated about that and say, I don't want to have to pass addiction counseling to speak to someone about these things that I really feel are driving a lot of my issues and my history here. I want to be able to speak to someone who I've selected and can form a relationship with that allows me to talk about these other things. And so integrated counseling in primary care is really useful that way. But again, there's a lot of people who just don't find it helpful, or they've walked that path before they've done it, they feel like they've addressed everything that they need, and what they really need is the medication to help them get through. And especially if they want to work or have their children or have other things to do, relegating 2 counseling visits or more a week, or even every week for several hours with time off of work, that's really inhibiting their ability to live their life. And just going back to the office-based versus home induction, Steve, yes, we haven't done an office-based induction, I think, in 2.5 years. We're asking people to be in withdrawal and then to sit in an exam room, and some withdrawal symptoms require access to a bathroom. That's also very difficult, and patients may want some privacy for, and we don't have comfortable chairs or spaces to hang out for several hours. So we're saying, come in sick and miserable and sit in our hard plastic exam chair, and we don't have private bathroom. People will see you coming in and out of the hall sweating and a mess. And that's just part of what you have to do to get your medicine. It doesn't encourage people to come in withdrawal. And we don't want to precipitate withdrawal with Suboxone. So we really need to get them to a place where they feel comfortable and they can take their medication without worrying about everyone seeing them or all these other side effects or judgment.
I was just going to concur. Thank you. That, in fact, we'll be happy to pass out these different resources, but ER settings like Yale have developed handouts, single-page handouts for people to start Suboxone at home because they've overdosed. They're in the ER setting. They can't start them right there, but they want them to start at home. And so actually emergency medicine has been a great ally in helping cement the approach of having home-based transition to Suboxone. And the word induction, which is often referred to, is also such a weird word, but again, comes from a methadone construct. I don't know why it's used. I think about it, I don't know, induction. Like we don't induce someone on blood pressure medication or induce their thyroid medication, but somehow this is some sort of specialized term. Very good. Okay. Drug testing. Previous approach, a tool to discharge patients from treatment or compel more intensive settings, and now really a tool. Just like any other medical test, it's a tool, it's a way of informing care, and to be used judiciously and to recognize the accuracy, knowing the accuracy of the test that you're using. Bassett uses a really good test, which I believe is a gas chromatography test, having seen the report. And that should be the standard of care. I'll show you in a moment why I think that should be the case. Prior approach was that people continued to use cannabis or stimulants or alcohol, and because of that, they can't have treatment for their opioid use, which will kill them. So that, again, doesn't hold up to scrutiny. People who continue to use cocaine still stay in treatment at really good levels. Often help for opioid use can help other use, but it may not. I think this is a complex area because polysubstance use of more than one substance is now absolutely the norm. And for patients, and we're really not in a model of I use OxyContin sometimes on the weekend kind of thing. Like I just haven't seen that in a while. Maybe selection bias, but it's just not how people are getting hurt by opioid use disorder currently. Lastly, as James alluded to before, maybe we'll use buprenorphine for a little bit of time and then time to come off. And now if it's still helping you, let's keep using it. And it's not really a topic of conversation that I have with many people from myself. If anyone wants to taper down, taper off, whatever they want to do, I want them to have agency over that. Just with the knowledge that if they do it in a time period less than 12 months to 2 years, that their odds of getting hurt are higher. But I don't have any interest in, look, I'm not going home with someone. Like if someone wants to stop it, please, that's the way it is. But it's for so long, the reflex has been, in fact, Maine only allowed 2 total years of buprenorphine in their Medicaid program, which is sort of like, why don't you be on your, your blood pressure medication for 2 years, and then we're going to stop it because you're all better now. I mean, it's just, it just doesn't sort of, again, it beggars the imagination. Okay, coming back to low threshold care. Why do we like it so much? It's on demand. Jenny gets that phone call from this person with his mom, and our job is to be nimble for people. There are these windows of time. Jenny spoke so eloquently about this one. Windows of time. People go through these windows unpredictably. Something happened. I want to get better. It's now 3:43. By 4:10, that window may be gone. So when we have the opportunity to help someone and show that they can trust us to meet the acuity that they have, it's such a good sign, and it forces us and should force us to make our systems flexible enough to allow this. Steve Martin does not get to choose when Josephine Smith wants treatment. Like, I don't get to, it's just, so my job is to help in real time. Just follow up for no-shows and transitions. If people don't come in, like, this is not like patient no-showed again, NSH, right? This is sort of like, hey, Steve, where are you? What's going on? Like, just showing a care, making it easy for people to come. We all saw that early graph showing people really dropping out in the first month. Like, this is really the development of a relationship that matters. However, medication all by itself, as people have alluded to, in the absence of a clinical relationship that's positive, tends not to work. But what also tends not to work, I've heard it over and over again, and it's just brutal, is not readjusting one's social milieu. One cannot sort of keep going with folks you're running with and using with, and then sort of keep that as in place while you're working to get into recovery, a stable recovery. It's too much. It's too much. So some of the concrete things that people have told us have helped them: a new cell phone number, deleting all their contacts, just not using a phone, just throwing it in a river. I mean, I don't care. That phone cannot be there, because people will get multiple phone calls a day asking them to use or buy. Social media can also be a nightmare. And this is like a good differential diagnosis question as to how much social media people are using, because it can either induce sort of a sense of, I've got to get back with that group, or I'm not doing as well as X. There are all sorts of reasons why social media could be curtailed. We talked about people, this is a positive point to be around others who are not using. Boredom is it is bad. Boredom is bad. And having time where you're not doing things that are making good use of your time is also bad. So this is like a lot of like grandma conversations, like, what do you do with your time? Wouldn't it be nice if I'm not trying to make light of it, but you're actually asking someone who's used their time in such a destructive way for months to years to actually start to create avenues for the time that they now have because they're getting better. Like, that's a powerful moment and an opportunity, and it's a skill. Like, it is a skill to do this. And so I think it's a very practical counseling area. I appreciate hearing what others might think.
Hey, Steve, sorry, it's just Jenny again. I think the other thing that you have to plan for is when they get their first job and their first paycheck, having money in their possession for the first time in a long time. What activities or other things are you going to do with that money, or what plan do you have for the money to keep you from having the urge to spend it on what you were always looking for money for in the past?
So Steve, Joe Sellers here. So I've always told my patients that I've never had anybody relapse from substance use or alcohol at a church. I've never had anybody relapse at a library. Never had anybody relapse at an adult ed course. But I've had plenty of people relapse at a nightclub, a barbecue or whatever. It's really hard now with COVID, though, to come up with suggestions. because people really are socially isolated. And particularly the kind of wholesome places your grandmother would have sent you to, those are the ones that are closed down by COVID. So it is difficult. And just when you were mentioning about the no-shows, it's amazing because I learned from taking care of no-shows with substance use what I was missing on all my other no-shows. Because no-show is a sign of social distress. And so some people it's transportation, some it's depression, anxiety, agoraphobia, some it's domestic violence, a controlling domestic partner. There's so many things that that a no-show should be a red flag for us. And so those are people we need to, what we're doing in our practice is we put them in contact with a navigator.
Yeah.
Say, okay, what do you need? You need, it's a financial thing. Okay, let us help you with your insurance. It's a transportation thing. Let us get you transportation. But for years, we've kind of looked down on no-shows as just being inconsiderate people. And I'm sure there still are a lot of them. But in that group, there are a lot of people that this is a sign of distress. And I just have to point out to my psychology colleagues, I still see in many mental health practices that no-show gets dismissed from the practice, where to me, no-show to a psychologist should be, this person needs more psychology work. So.
I don't think you'll get any disagreement from the psychologists on this Zoom.
Yeah, agreed.
Yeah. And the nice thing, Joe, not that, whatever, this idea of this, I don't mean to, the telehealth, because of COVID, our colleagues in Barrie have had their no-show rates have plummeted. And, those patients have a story, which is, I just never could get there for X, Y, or Z reason. And it's just very, so good to know that there are ways around this that have existed for a long time. And we have had our, we've been bound up in certain ways of practicing care that don't align with what works for people. So it's very powerful to have people have access again in ways that they haven't or have access now. Just a couple more ideas here. Sometimes having a family or friend, I'm going to come back to Jenny's point about having a family member hold your check from work. Again, people that someone has to have someone trusted, but they only have to have one person that they trust. Like, that's not a lot. One is better than zero, and one can help a ton. And then finding ways to fill the day with structure. So just want to come to this idea of what we're seeing in the US currently. This is published late last year as well, actually early this year. Viewing opioid trends in a silo ignores the fact that polysubstance use is ubiquitous and that significant changes at polysubstance use should be monitored. So, yeah, I think this goes back to what we were describing before. And in almost all cases, the benefit-risk ratio favors use of buprenorphine with the ongoing polysubstance use someone is having. That my personal bailiwick has been limited to people who are drinking so much that they're actually cognitively blunted and aren't really using much in the way of executive function at all. And yet I still almost always continue with buprenorphine because they're still alive, and my tools to help that person are pretty limited. I find that to be that for me is a horrifying situation. I really But anyway, just to point out that this is it's sort of a limited group of people who won't do well with buprenorphine. Here's a study again looking last year that cocaine is now involved in a tremendous amount of overdose deaths. In the West, this is really methamphetamine, Midwest, and we're seeing more crystal methamphetamine here in the Northeast, certainly. And sadly, we've avoided it for quite a while and no longer. And just to emphasize, again, even alcohol use we can do so much good work with it. And about 40% of people with an opioid use disorder have an alcohol use disorder. It's a large minority. that you're helping with. So I have here a number of slides that sort of give some nice sort of context, but I'm going to skip over them because you will be getting the slides and there will be no quiz or anything like that. I do want to come to this idea of testing because testing is like with COVID-19, testing has this air of objectivity to it that is false. So all tests have errors. The question is, does the person doing the test know that there's an error rate? And what is the error rates? So if you don't know, then you can't really do a good test because you can't interpret it. So we generally test urine nationally for toxicology, but at our site, we've deliberately instituted saliva testing for the past 4 years, which has better accuracy and also allows our lab not to be awash in urine, which is what was sort of happening before. And urine itself presents, a number of problems in terms of chain of custody. Is it adulterated or not? Like, those are a lot of questions that consume a lot of time. That's not useful. But I want to come to these pictures. So this is a point of care test. You may have seen these, I don't know or not. These are actually, they're for sale in pharmacies. And this is a immunoassay test. And this is the last one on the right is a gas chromatography double tandem mass spectroscopy test. So our only quiz for today for me is which of these is the least expensive? I'm looking for a lot of chat answers. Just go for it. Just don't hold back. Man, just point at the screen which one you think is the cheapest. Yes, say Jenny, I see you. Yes, I see you.
I mean, it's in the slide, so I'm going to cheat and say for one.
Oh man, see, you've got to tell me that next time. This is a Zoom mistake. Yes, as Jenny has noted, the point of care test is the cheapest test. Now, why would you do the cheapest test? It's a different question. Because it's cheap. Because it's cheap. Yeah, see you, Mike. Thank you. We'll send out the slides. Thank you. It's cheap. So is the cheapest test the best test in terms of accuracy? Generally. I'm answering all these rhetorical questions myself, and the answer is no. We would not have the test in the middle or the test on the right if the test on the left was awesome. If it was an awesome, super cheap test that was super accurate, that's what we would use. That's why we use home pregnancy tests, because they're cheap and wicked accurate. We do not have a drug test like that. And your odds of having a false positive or a false negative here can approach up to 50%. So why do the test? Because the recommendation will be to confirm all positive tests anyway, which means you're going to be using the middle one or the right one. Thanks, Julia. Oh, thank you. Yeah, I'm very grateful. So just, this is a very high, level. These are not equal to each other, and know what test you're doing. And why is this a problem? Because people suffer harm when we use inaccurate tests. They are sent to jail. They are kept in jail. They are incorrectly interpreted by their healthcare provider. They have their jobs affected. So if you're going to use a lab test, as we saw before, the major reason is to support a patient in their recovery, and to see if they're taking their buprenorphine. That's really the only reasons I can think of. But it is not, the testing is not useful in terms of making sure someone's not using, because they may be, and then you have to have a low stakes answer to that, but not a high stakes answer. Okay, all right, lots of that stuff. Okay, and then sadly, as Amber alluded to earlier, there's no surprise that anxiety, PTSD, and other mood disorders are highly correlated with opioid use disorder, and that finding ways into those experiences for patients is really vital for their care. And as an asterisk, many people just feel better because their use is not as bad as it was, and they feel like they have more control. And that does quite a bit for people's anxiety and depression, thankfully. This is the last slide, just in general, because this is during the pandemic and sort of an unusual time. And I know that we're just getting sort of started in your work, but the recommendations are really to favor allowing refills to people and not having them come in for drug testing that's essentially not going to change their care. So just recognizing that the risk of being without care during the pandemic is really salient, and that we have to guard against it with requirements that we make for patients. Wow.
Can I just jump in? I really appreciate the plug for behavioral activation. It is a treatment that is fairly simple to understand and deliver, and also has some pretty good evidence of efficacy, particularly with depression and anxiety, as Steve indicated. A really quick way to sort of explain it to a patient. You can, well, we used to draw when we were sitting in the same room with patients, but it's essentially sort of illustrating the cognitive triad. So you build this construct of depression as sort of this interrelationship between thoughts, feelings, and behaviors, and understanding that when a person is suffering from depression, all of those things tend to be impacted. And you can give some quick examples. Behaviorally, you might talk about sleep or eating. Thoughts, you might talk about sort of unnecessarily, unrealistically negative views of self or person. And then feelings are pretty self-explanatory, feeling sort of lack of energy down in the dumps. And with that in front of you, you can talk about, if we want to sort of intervene on this syndrome, we have the luxury of being able to intervene on any of these three domains. And we've got tools for each of those. We have medications that can try to, as directly as possible, try to go after those feelings. We've got the C in CBT, the cognitive interventions that try to help people change the way that they think. And those are really powerful. But we also have behavioral interventions, and we can sort of turn on its head the way that we typically tend to think about how we get better. I will start doing more when I feel better. Not a bad idea if it works, but if you're sitting there talking to us about your clinical depression, that has not happened yet. And so we encourage people to sort of flip that on its head and engaging in almost any behavior that has an amount of value to that patient has a decent chance of trying to lift that depression up just enough to start to build some momentum to do bigger and more valuable things. So I'm sorry to get into the weeds on that, but I just think that it is a hugely powerful and pretty simple to deliver intervention that folks can do, whether you are a primary care clinician, whether you are a psychologist, whether you are a nurse. Anybody can get sort of that 5 to 10 minute script and understanding of behavioral activation and start trying to use that for their patients.
Yeah, that's great, James. I so agree. Well, why don't we dive into the last piece, and then I'll be sure to save a good 15 minutes for discussion and questions. All right. So let's see here. Share this. All right. So what we're gonna wrap up today with is something that I mentioned in my introduction, which is really I've become very fascinated with just the theory and the thinking around harm reduction, and really am trying to put energy into using some already existing literature. This is not new. Europe's been doing this for decades. America's been slower. But this is already very well thought out theory around human behavior. And I really just want to synthesize it in a way where it's practical and available for medical providers on any, in any discipline to use to help us just kind of navigate these, what kind of seems like sort of treading water with these patients, because, it's difficult work at times. It's very easy and rewarding in some ways, and at the same time, it's also challenging and difficult. So, this really sums up the reason why harm reduction is such a no-brainer to me. Really, I think a lot of policies and initiatives have taken a very rigid zero tolerance stance on risky behavior. And I love this particular quote, which is, again, people have been using psychoactive substances for centuries. People are not going to stop ever. And the time and effort that has been allocated to try to eradicate intractable human behaviors is really kind of ridiculous when you think about it. And we need to be funneling attention on how to keep people alive and to reduce harms. And so that's a really core principle. This is a definition that I kind of smashed together from a lot of different places. So bear with me, I'm gonna read this out. Harm reduction is a pragmatic and compassionate approach that is grounded in justice and human rights, that focuses on helping people who use substances. Harm reduction approaches focus on positive change and on working with people without judgment, coercion, discrimination, or requiring that they stop using substances as a precondition of support. Instead, it represents a spectrum of strategies from safer use to managed use to abstinence in order to meet people where they're at. In doing so, it aims to open pathways for change while reducing negative consequences of substance use for both the affected individual and their communities. So harm reduction, kind of an umbrella term, can kind of seep in a lot of areas: federal and state public policies, legal criminal justice systems, local communities, healthcare policy. What I really want to shift your focus on is really, how does this seep into the one-on-one, in the moment communication that you have with patients as you start to expand your work in this area? And that's what I'm using. I'm not the first to coin this specific term, but I think this kind of captures it, which is really harm reduction informed care. How does this show up and come through in how you respond and react to patients, and what information you give and how you approach your patients? So it's really the application of well-established harm reduction principles to inform the actions and responses and communication between a provider and patient, especially in the context of ongoing substance use and other high-risk behaviors. Again, this is, reducing harm is such a spectrum of lots of different factors and actions. It really is anything that moves someone down this continuum of something that has a high potential of harm to something that has a lower potential of harm. And that can mean so many different things in people's lives. So I do want to give you a little bit of a snapshot of this data. They redid this study in 2018, very similar results. So this is looking at the people who endorsed and filled out a questionnaire suggesting that they likely met some severity level of a substance use disorder. And the graph on the left shows the number of people who received treatment in a specialty facility was 11%, and 89% of these individuals did not receive any treatment. So let's look at that 89%. Of that 89% on the right here, 95.5% did not feel that they needed treatment. Those individuals are definitely going to benefit from harm reduction, right? Like if they have some sort of problematic substance use, they did not want treatment, they need to have access to things that are going to keep them alive as they're navigating that substance use. Now let's look at these other two categories: the people that felt they needed treatment and did not make an effort, and people who felt they needed treatment and did make an effort. Okay, so this is going to capture both of those. For the people that needed treatment but did not make an effort, the reason that they didn't make an effort, 40% of it, 40% of those individuals, they were not ready to stop using substances. When we jump over to the they needed to make treatment and did make an effort, but they ultimately weren't able to access it. Number one barrier, obviously that makes sense, no health insurance. Number two was not ready to stop using. And I think this is one of the lingering detrimental effects of some of the early philosophy around AA and the 12 steps, which is really this idea, there's no other chronic condition in which someone is discharged for exhibiting the symptoms that are causing that disorder. Like, it just is completely backwards. It's this idea that you have to totally stop using all your substances in order to access the treatment that's supposed to help you not use those substances, or to use them to a lesser degree. So in this next slide, I really, this is kind of a mental experiment that I use to kind of help us gain perspective about our role with patients. So I want you to look at this continuum, and all the dark blue is that the patient engages in some form of treatment. It could be, buprenorphine in primary care, it could be going to a residential clinic, it could be an outpatient treatment center, and all the red dots are a return to problematic substance use. Now, I want to be clear that part of why we know this is you can retrospectively talk to patients. They have been in and out of different forms of treatment, right? We know that it's a chronic condition. It's not something where you go to treatment and it just shuts off. But the reason why I want you to think about it in this way is I want you to kind of imagine, where are you potentially interacting with this patient on this continuum? And to put into perspective, because again, I think mentally as providers, healthcare providers, we want to help our patients. And how do we know if we're helping them? Well, we see some result that we've identified in our own mind is a marker of change. And naturally people think, reduction or cessation in substance use. So, but if we are too rigid in making that the goal, or only seeing that as the marker of success, we really set ourselves and our patients up for disappointment. When you look at this chart, you may not be interacting with a patient at a time in their journey where they're going to reach their sustained abstinence or moderation. You may, and you may not, but to take that perspective, I think, is really key and really important, because it also shifts the perspective of, how do I reduce harm? How do I make it so that this person is more likely to potentially in the future reach that ultimate sort of sustained abstinence? Right now, I'm working with a woman who lost custody of her child and is living in her car, and her family doesn't want her to live with them. And I'm actually incredibly amazed at how much she has reduced her heroin use, but she's probably not going to totally stop. She is not totally stopped, right? The conditions of her context are such that it is really not feasible when you really put your perspective into that patient's life, that she's going to totally stop. And for any provider to insinuate that should just happen is really invalidating to the context and the circumstances that prompt substance use in the first place. So I think this is helpful. That's a helpful perspective also for me, right? When we're in it and we care about these patients and we're just frustrated, we want them to get better, and we know that they're heading down a path, we have to gain that perspective. So along this continuum, harm reduction is really, what are the doorways that our healthcare system, our society, what are the doorways that open for people? And traditionally, the doorways open when someone's in the action stage. So just a reminder, actually, I'm pretty sure most of you know what this is, stages of change, right? And just that it's not this black and white thing. We kind of, go through different variations of change. Pre-contemplation being, I'm not interested at all. Contemplation, I can see some benefits in changing, but I really am not quite there yet. Preparation is, I think change is probably a good thing, and I need to make preparations to be successful, and action is actively, following through on some of the behaviors associated with change. And our treatment system has not opened doors along this continuum. It has really been focused on action. And we really need to open doorways for social service supports, for healthcare, and for treatment along this continuum of motivation and desire to change circumstances and substance use. This is another way to depict it, which is kind of thinking about these red dots on the right-hand side. And, you know, I think Dr. O'Reilly talked a little bit about this too, like these positive change opportunities, these moments in which someone is at this place where they, you know, that the voice in their mind of changing circumstance and getting treatment, you know, starts to speak up a little bit. And the unfortunate thing is that that moment in time, right, like that open in the, you know, in the universe, may close in 5 minutes. It may close in 7 days. It may, you know, it may close in 2 weeks. We really need to make those connections with individuals closer to those times in which there's a chain. You know, you can kind of throw them a lifeline in that moment. So another really important part of harm reduction, again, we're taking a lot of, let me say one thing too, that part of why I was really drawn to harm reduction, like I said before, I felt like as I started to treat patients with substance use disorders, it was less that I had to learn things, because everything that I was taught as a psychologist, motivational interviewing, CBT, behavioral activation, all of these things are evidence-based treatments for substance use disorder. So it was more about what I had to unlearn. And harm reduction really was this sort of perception and guiding sort of framework that really helped me make sense of what kind of care do I want to deliver, and what did I hear that doesn't really jive with me. So as part of harm reduction, you know, it's really about taking a very flexible and nuanced outlook on substance use, and understanding that it is on a spectrum. And, you know, a patient can come in and have an active issue with opioids that they're receiving buprenorphine for, and they, you know, recreationally use cocaine. Just because they use cocaine doesn't mean that they have a cocaine use disorder. And so this spectrum really, I think, illustrates that diversity of use. So obviously no use is no use. Experimental is a person is just curious about the effects, right? You know, most people at some point in high school have experimented with a substance. That's the norm. I don't think people talk about it because there's a lot of stigma, but a lot of people experiment. It's part of the human experience. Some people use substances for direct health benefits, right? We think about using marijuana for chronic pain. And those may or may not be prescribed by providers. Then you have people who have occasional use, which is kind of like social or recreational, where it's kind of combined to certain events. Then you've got people who, you know, the use of the substance is more predictable. There's a pattern. It's more consistent. You know, it may be a way to cope with stress, which is not inherently a problem. But thinking about regular uses, it's not quite causing problems in the person's life. It's benefiting them. The benefits are outweighing any potential risks. Now, when you start to get to heavy and chaotic, this is when we start to see problems arise. And heavy use is really where a person is using the substance to an excess, and is more vulnerable of having higher risk scenarios with the substance use. It might start to occasionally negatively affect areas of their life. For example, you know, they're not able to show their child as much love and attention they want because of the effects of a substance, or issues in the relationship, such as the partner being upset with the frequency that their spouse is intoxicated. And the person might actually meet criteria for a mild substance use disorder. And then lastly is sort of what we understand of as addiction. And this is where, you know, the person's thought processes and actions are really dominated by the use and desire to obtain the substance. Really negative consequences start to occur on a more consistent basis. They start to experience emotional and physical harm because of the use. And there's a lot of trade-offs that they have to make to sustain the use. Again, remembering that, and again, I think that in my work with providers, both, and I train physician residents in a family medicine residency and work with PCPs in my practice, and I do think that it is not the common default to remember that spectrum of use. If a person is using a substance, it's kind of automatically assumed that it's a problem and they shouldn't do that. So remembering that spectrum of use is really important. So this is another, this comes back to some of the things that I've said about context, and really context really drives the relationship that we have to substances. So Zinberg, again, he wrote this book on this topic, and I have not seen it as widespread as I would expect it to be. But this is a really, really helpful way of understanding the context of substance use and why some people use substances in a moderated, controlled way versus people who go on to develop a more severe substance use disorder. So thinking about the use of a drug within this framework, I think, is really, really helpful. So drug is just the drug itself, the type of the drug, the mechanism of action in the brain, what it causes the person to feel. And remember, that's different. Each drug can have 10 different effects on the people using it, right? There are some people who take opioids and they feel really sick and they're like, I don't want to ever use that. Some people take opioids and they're like, I feel like an entire force field of fear has been lifted from my mind. I've never felt this good. I've never felt more like myself. The route of administration is a factor. How much is used, how often it's used, and then whether or not it's used in combination with things. The set is the mindset at the time of use. So what is the general mood at the time of use? What are the psychological factors? Is there depression? Is there stress, loneliness, anxiety, irritability, physical pain, excitement, joy, expectations of the use, right? So what does the person expect out of the use? Do they want it to help relax or to relieve pain? And I think this is a common one. I just gave a lecture to a group of medical students, and someone had asked just about well, if you give someone who's on buprenorphine or methadone an opioid for pain relief because they're having, really complex back surgery, you have to understand that the context is different. To understand that context is they're taking the substance in a certain way. It's administered by a healthcare professional. The mindset is, I want pain relief. It's for medicinal reasons. The expectation is that it is going to help me get out of pain. And those factors, and it's being administered in a controlled environment, all those context variables are encoded in the brain and how the drug memory is stored and how the brain reacts to that drug use. So understanding that the expectations are really, and also like relief from withdrawal. I have a patient just over the week, and I was talking to his intensive care coordinator who said that he relapsed. Well, his buprenorphine and all of his medications were stolen, and he had no way to pay for them. And we wrote him new prescriptions, but he would have had to pay out of pocket. He didn't have that money. And he used heroin. That's not a relapse in my mind, right? And I agree with Steve too. I just want to try to get that word out of my head, but let's think about the set and the setting. He was medicinally using the heroin to relieve himself from withdrawal symptoms because he didn't have his buprenorphine. All right, and lastly is just immediate context and situation and environment, and understanding that setting is the immediate setting, but it's also the broader backdrop social context of the individual, such as things that they're facing, such as housing insecurity, poverty, domestic violence, exposure to discrimination, whether or not they're in a developmental period, such as like adolescence, early 20s. And just one, I'm just going to go through just a couple of these for sake of time. Like I said, you'll have access to this, but just to put this in context a little bit. We've got, let's look at the first one, or I actually kind of described that one in just a minute ago, but hydrocodone oral, the set, apprehensive, stress due to pain, expectation, pain relief, better sleep. Immediate setting is back surgery. General setting, stable basic needs, desire to return to work, provide for family. And let's contrast that with the heroin intravenous, right? So mood, depressed, anxious, expectation, desire for anxiety, and withdrawal, relief from withdrawal. Immediate context, using alone in a friend's bathroom, hiding it. General is homeless, couch surfing, and difficulty finding work. Like, these are completely different scenarios that all of these factors taken into consideration affect the use experience and also affect the relationship that the person has with the substance. So in terms of this idea of choice and control, and there's a, this is incredibly powerful. And it, you know, one of the more important things I think everyone who's doing this work needs to hear and kind of understand. So because of the moral model of addiction, there was a really big push in recategorizing, really rethinking about addiction as a brain disease. And that is really useful in a lot of ways. But what happens is we tend to have these pendulumed ideas about these constructs, right? So if you overly rigidly think about it as a brain disease, you also might be vulnerable to thinking that that person is completely out of control, that they need sort of like coercive methods to access treatment, that they can't use any substance, otherwise they're going to, you know, catapult into a week-long bender. On the other hand, if you don't appreciate the influence that a substance use disorder has on the person's decision-making, you also are at risk for sort of overly emphasizing their choice or blaming, right? So these constructs are so important. So I want to give you some words and a description that I think provides the nuanced gray approach to this. So, and I think I'm going to get to this on another slide, but you know, what we know about substance use disorders in the brain is that kind of the most sort of neurobiological description that I can give you is that the brain's mesolimbic reward pathway, basically for people who have a substance use disorder, the mesolimbic reward pathway is almost like it's hypersensitive to external reward cues. So, you know, we all experience this, right? You drive down the road and you see a sign for your favorite fast food place, like it's going to cue up the reward memory that's associated with the time that you shoved your face with that delicious greasy burger. Like, this is an innate thing that we all have and that we all experience. People with substance use disorders, basically their brain overly tags things as reward cues. And then when they encounter that reward cue, that same mechanism that says, oh man, I really want a burger, is jacked up to, like, you know, 100 times. And the person experiences an incredible force to have that substance. So I want you to think about that mesolimbic reward pathway and its hypersensitive response to external cues, which is what contributes to the craving and the desire to have the substance. Not to mention, so, you know, for example, it's probably very rare for, you know, someone without an alcohol use disorder to have constant cravings for alcohol, right? So I don't crave having a glass of wine on Monday morning, right? Do I crave having a glass of wine on Friday night when I don't have to go to work the next day? Absolutely. For someone with a substance use disorder, that craving is tagged to so many more contexts that they have to fight throughout the day. So the way to reword this is really, instead of these extreme interpretations of control and choice, to understand that it's more helpful to focus on the variable strength of influence of the SUD, which is essentially the mesolimbic reward pathway. That it's more helpful to focus on the variable strength of influence the SUD exerts on a person's decision-making and behavior. The strength of that influence fluctuates hourly, daily, or weekly, based on a person's mindset, motivation, context, relationships, and many other interacting biopsychosocial variables. Super key. This is really helpful. We're going to come back to this too in terms of some language that I think is important for us to talk about in terms of reducing stigma. Just checking my time here. So what I'm going to do now is I'm going to segue into, you know, this slide sort of depicts person has daily use of opioids. They enter treatment with you. You start to prescribe buprenorphine, And, for some patients, like, they really almost immediately stop using opioids, right? That happens. And that's, really awesome as a prescriber and a provider. It's usually, it's not the rule though. Most people struggle with a period of intermittent use of opioids that has variable lengths and severity levels. So what I'm about to describe to you next is really this guiding sort of way of thinking about what do we do in these moments? How do we respond when a patient comes into the clinic and they're the opioid use disorder has flared and they're really struggling with use of opioids, even though they are engaged in care and receiving buprenorphine from you. So this is a really awesome article that I found just within like the last year that basically did some of the things that I was thinking about in terms of trying to categorize these principles in a more succinct way, really for consumption from in healthcare settings. So I'm going to go through each of these pretty quickly. Again, you're going to have a copy of the slides, but this is going to really anchor you in how do we think about working with these patients, especially in the context of ongoing use. So humanism is really, it's respecting and dignifying patients as individuals. It's really respecting that people do things for reasons, and substance use serves a function for the individual. It is human tendency to be drawn to short-term versus long-term benefits and priorities. This is human. Yes, this is amplified to a greater degree for people suffering from addiction. It also means recognizing that harmful behaviors provide the person some benefits. And really the benefits have to be explored and understood to really understand the person's experience, right? It's understanding that people don't just start their day with, man, I really want to, inject lethal drugs into my veins and take my life into the dumps. Like it is not this, it is such a complicated behavior. And for a lot of people, even though the current use may not be providing the benefits of the initial use, the use experience itself and the reward context neural pathway in the brain usually came because it had some sort of benefit. It helped them in some way and likely still helps them to some degree. It's really, I think important to understand why patients make decisions. And, not why did you, not focusing on, wow, that decision was really risky, or let's talk about the harms associated with that decision, but why they made that decision, what went into making that decision in that moment is really important. The humanism part also, reinforces the autonomy that patients ultimately are the drivers of their life. And recognizing that ambivalence and resistance to change are human, and it's our job as healthcare providers to explore ambivalence and not confront it. So pragmatism, this is really targeting this prioritizing of actual harms to individuals and societies, not moral failures. It's really utilizing practical approaches that are short-term, concrete, and really most importantly, they're rooted in the experience and social context of the patient and tested within that context. So going back to my patient who is homeless in her, I think there's a lot of suggestions or interventions that could be communicated to her, or if I really emphasize, hey, we really have to go back and talk about the heroin that you used 2 days ago, and this is, I'm worried about you, and this really isn't, this is going to cause harm, and I'm really concerned about, that really does not match her context. And thinking about the ways that we talk may be coming from a very biased, idealized versions of what that person is capable of in their life. And I think some of this also comes from, issues that people face from poverty, and understanding that the barriers are so complex that really just making an effort to really understand and learn about those barriers is so important and goes such a long way. It's so important that we don't provide solutions that aren't really viable in their world, and therefore aren't achievable or helpful to them, and can kind of risk that cycle of blame and disempowerment for the patient. Really focusing on short-term realistic goals that can provide quick benefit and establish agency. And again, this last one is I think really important too, where it's recognizing our silent expectations. That kind of comes back to that that overview sort of slide that I talked about, where we may have really high expectations, and really monitoring what those are and how those are showing up within our conversations is really important. Individualism, this is really face valid. Tailor interventions and messages to each person. Really reminding ourselves of the complexity. What works for one patient may not work for the other. And no two people recover in the exact same way. Autonomy, again, very face valid. It's really, there's a lot of, it's very symbiotic with motivational interviewing and the principles of motivational interviewing for sure. So recognize that as providers, we can offer suggestions and education, but ultimately patients are going to make their own decisions. And I think it's really important because this is a population that feels very disempowered, and we really need to verbalize our respect for their ability to choose what they want to do. And patients may choose to continue to intermittently use substances, and at the same time still get life-saving effects by being on buprenorphine. Yeah, and I think this one too, that patient-centered care and shared decision-making and absolutely reciprocal learning. I learned so much from my patients, and I'm able to do that because I open that door. That's a conscious door that I have to open. And the last two here, incrementalism is really here. So a big part of harm reduction is really noticing positive change. There is positive change even in episodes of use. So for example, I have patients who will start to do test shots of their heroin to just kind of gauge the potency. I have patients who notice that while they are using, they're starting to have different thoughts come up in their head. That's positive change. They're starting to have different conversations with the people around them. They are trying to get some of their social sort of service challenges in order, like trying to get an ID or trying to address a warrant so that they can kind of be released from the issues that is having for them. Making progress on getting an ID is positive change, and is success. Recognize that it's just a slow process, and ultimately that success is not bound to abstinence. That's really key, and it's really defined as any step towards positive change that is meaningful and ultimately defined by the patient. And this last principle is really key here too, and you heard Steve talk about this, which is accountability without termination. So patients are responsible for their choices and health behaviors. We can hold people accountable for the goals that they set for themselves. That's really why that's such an important part of this process. What is it that you want in your world, in your life, that the substance use disorder is robbing you of? Where do you want to go? And we can help hold people accountable for those goals. So understanding that patients are not fired for not achieving goals or treatment outcome ideals. Backwards movement is not penalized. People have the right to make harmful health decisions. And our role is to really help give them a space, like Steve said before, unconditional positive regard, a non-judgmental zone to help them try to understand the causes and consequences of their actions so they can learn about their experience. So I'm going to move past that because Steve covered it. And I think that one of the other really important things to understand here is that harm reduction, we've actually gathered qualitative data from patients, and patients really, this works for them. This is endorsed by patients. And so I'm not going to go through these, but these are all different kind of specific examples of benefits that patients have had within harm reduction models of care. So stigma, one thing that I want to say, and I kind of, I think about it as kind of akin to some of the ideas around racism and implicit bias. So, none of us chose to grow up, to grow up in a society in which racism was rampant, right? Our brains have encoded racist ideas and messaging without our consent, and have influenced the experience of implicit bias, right? The same construct applies to substance use disorders, right? Like the way, and there's a huge overlap between drug use and racism, particularly towards African Americans. They were sort of seen, right? Like those two things were connected, and that's part of what really promulgated the high incarceration. The Rockefeller laws were like any possession was met with an insane sentence. So again, I want you to think about stigma and implicit biases that we have, that they're implicit in our heads because of the society that we grew up in. We learned through messaging, and that certain ideas about what it means to be someone who struggles with addiction. And so I think we need to really look at it from that context. That's going to help us. Again, I'm going to show you kind of two versions of data and studies, one done on healthcare professionals, the other on just more general population. But these are the kind of the main stereotypes for patients with substance use disorders, that they're dangerous and unpredictable, that they lack the ability to make treatment decisions, that they're more to blame for their condition, they have more controllability, that people, can pull themselves together without treatment, right? They don't need treatment, it's a choice. And immorality, characterizing, with sort of moral terms. I'm going to just kind of click through this because I'm looking at time. This is healthcare professionals. Again, this is just meant to provide support that these things exist and the stigma is there and those implicit biases are there, and we need to monitor them. This is a way that I've sort of conceptualized where it's vulnerable for us as clinicians, which is really, this is a very complex situation. And this applies to whether you're a medical provider or a behavioral health provider. But when you have a patient scenario and you have a level of perceived responsibility. So the perceived responsibility part of this is, a belief that a clinician has complete responsibility for the well-being of the patient. Where we can be at risk is overestimating our ability to influence or control a situation, right? It's my job to get this patient to stop using opioids. That is a really high, unrealistic expectation, right? So, I mean, because you don't have the ability to stop a patient from using, right? So to the extent in which a clinical scenario incorporates this perception of responsibility, on top of that, then you introduce this idea of clinical uncertainty, right? The fact that the condition that you're treating involves, human behavior and self-management that play a strong role in outcome. And there's no clear, known, definitive, effective treatment pathway or outcome. And then lastly is the perception of level of risk. And this is a subjective assessment of how risky a certain patient behavior or symptom is. And this tendency to, we tend to equate risk with actual harm. Risk is a probability, not a certainty that harm will occur. This is kind of a conceptual understanding of what makes providers of any type vulnerable to really overly directive or coercive messaging. Again, this is a really complex situation, and it's really just about noticing our own vulnerability as clinicians when these sort of context variables are at play. One of the things that I think is really, part of this harm reduction informed care is really reinterpreting patients' behaviors. This goes back to the conversation around the mesolimbic reward pathway and how it influences decision-making and motivation and choices. So we really need to be aware of how we describe patient behavior, aware that we're influenced by stigma and bias. And we really need to adopt a perspective in which the language places the behavior of the patient in context to what we know is influencing the brain. So, and also reinterpreting the patient's behavior from a perspective of self-preservation. And this really takes a thoughtful effort. So this, I'm gonna move through this hear. So here are some examples. I'm just gonna do the first one, and leave the rest for you to review on your own. But so example of the behavior. The first one, yelling or being rude to clinical staff. The perspective shift and putting that behavior in context to what we know is going on regarding the mesolimbic reward pathway. This patient has a greater difficulty regulating and inhibiting emotions. The patient may have misinterpreted a statement or action as a threat, a common experience for people struggling with anxiety. I wonder what physical and emotional states that may have made this patient vulnerable to an aggressive outburst. Is the patient overwhelmed by fear of withdrawal from a substance? And again, I think, so the column on the left is just, I think, some common situations that we all encounter in doing this work, and really matching it with a language shift and how we understand what's going on. And I think this is incredibly important. All right, let me check time here. I just have a couple more slides to go. I think it'll be about 4 more minutes, and then we'll transition and talk about any questions. So this, again, there's going to be some more information on here you can read. This is something that I've sort of created as a point of focus. What is kind of this guidepost when you are in the room with a patient who discloses to you that they have engaged in ongoing substance use, whatever the context. These are the things that I really advocate for you to focus on as a clinician. Prioritize the patient's perspective of the use. Work to identify any positive change during the recurrent use. Emphasize the perspective of opportunity versus setback. So really facilitate that it's data, it's information, it's learning. Verbalize the acknowledgement of the function and benefits of the substance use within that context. I can really imagine that it was really hard not to use in that circumstance based on everything that you have going on in your life. Verbalize recognition of the aspects of the social context that make it difficult to reduce or stop use. And lastly, verbalize an integration of harm reduction interventions during opioid use. So, and I haven't, so this is a graph that goes through each of those and gives a little bit more of a description of it. And then I also give you sort of an example, like a behavioral anchor, like a question that you can say, that question you can ask, or a statement that you can provide that really embodies that particular principle. So, and what I'm going to leave you with today, this last part here, is just to go through the harm reduction intervention part. And this is really these specific things that really are interventions when the person is having a flare in their opioid use disorder and they're really in a cycle of use that is concerning. And this is, what are the things that we can offer to reduce harm, even though substance use is occurring? So first one, access to infectious disease screening. Education on the ways of reducing risk of overdose. So really educating patients around the central nervous system and what happens when multiple central nervous system depressants are on board. Engaging, getting patients to test their opioid supply to see what the dose, what the intense potency is like. Wound care, right? Patients who inject intramuscularly, develop abscesses. And I think one of the things you can do as a medical provider is just really make sure that patients are cleaning and monitoring those issues. Making sure a patient knows about the medical issues that really require immediate attention. What are the signs of infection? What are the signs of endocarditis or cellulitis? Having access to contraceptives. Connecting patients to support programs. So these are two organizations that do not sort of advocate abstinence only. They are moderation and harm reduction, safer consumption. Reinforce just continued follow-up with your team. Even if you're struggling, I want you to know that I want you to come see me. Even so, if something happened, I want you to know that I'll be an ear, I'll give you a listening ear and try to help you the best way I can. Keeping them engaged in that relationship is so important. Obviously, we've talked about this, the naloxone education. And then this is a really interesting approach by one of the really, I would say, kind of the thought leaders around harm reduction, Andrew Tatarski, really created an optimal use plan, which is sort of, it's kind of the version of a crisis plan for patients who have really struggled with suicidality. It's really thinking about, if I do have a craving and the context is such that like it's just so powerful that it's happening, that there's some forethought in how you're going to use to try to mitigate risk. And there's a ton of resources on Harm Reduction Coalition's website specifically on safe injection practices that are co-created by clinicians and patients. I'm not going to go through this. I'm going to leave you with my last little quote, which is my favorite quote. And I end all my presentations with this. So it is, substance use represents a relationship and attachment that offers significant support to the person. Treatment must offer that support as well as the respect that maybe we can't do it as well or with such reliability. Whew. All right.
Wonderful. That was really good, Amber. And thanks to everybody who's been here today. I know that this is a lot. It is important information, but particularly in sort of a Zoom format, I know that it can be a long time to stay focused and intent. But with that note, I mean, I wonder if there are any questions or comments that folks would like to talk about over the time that we have left.
Mm-hmm.
Hi, I'm Elizabeth. I do have a question. Since the program I'm looking at doing, it would be on the other end of hopefully when a person starts going down that sobriety road or chooses to go down that sobriety road. Is there a united consensus in the medical field of a timeline of what's considered that road of sobriety? Is it 6 months? Or is it really truly an individual basis on the patient?
Yeah, so I think that's, and so your question is like, is there like a marker of time in which a patient has met their substance use goals and they're considered like you said, in sobriety?
Correct.
So I'm going to share my honest opinion about the word sobriety. So bear with me here. I don't want to discourage you from using it, but I do want to share that I have a little bit of a reaction to the sort of the binary sober, not sober, right? It's sort of this label that is not as flexible as I wish it would be to the fact that it is this chronic condition that, I want to connect this dot a little bit to, there's a very common experience where people will have, several months to years with no use. And coming back to what I was saying about those context variables, and the fact that the neurobiological nature of a substance use disorder lives in that reward pathway, that reward pathway in the brain. And that system can activate drive to seeking a substance before a person is even consciously aware of it. That's how fast it is and how sort of overpowering it is. So a person can be like, consider themselves in recovery or sober, whatever it is, and they encounter a context that just too closely activates a reward cue, and their brain kind of leads them down the path of use before they even really notice it. So when I think about that language, I really, it's really a chronic condition that flares and remits, and people can influence, right? People have, mental health disorders, substance use disorders, they pull your brain in a direction without your consent, right? You are pulled into a depression, you are pulled into an anxiety, you're pulled into craving and desire and, to use. We have influence to kind of pull back, but sometimes the pull is so intense that you don't have that ability to influence. So people have agency and people can influence these forces in the brain, but the forces can also influence them unexpectedly. And I think creating a language that offers that flexibility and complexity for it to be, and because what happens then is that person who finds themselves using has grown up in a world that has only now blamed them. They failed. They did something wrong. No one is telling them, let me tell you about what actually is going on in your brain that really set you up the neurons in your brain all voted for you to do that without your consent. So I don't know, let me pause because I'll just kind of keep rambling, but please share your thoughts or questions you have about that. And I'm hoping that some others can comment too.
No, that does help, because I think the biggest thing with our program is we want a non-judgment, non-shaming environment. And I don't want to come in with stigmas or false definitions or what was perceived because society said so. I want to make sure, that's why I asked to be a part of this today. And I just want to make sure that I'm on the right path of completely understanding addiction, because I certainly don't want to set up an environment that is going to set someone up for that feeling of shame and judgment, because I certainly understand that we already do that, and I don't want to be a part of that.
And I just wish there was so many more people just like you sitting on this and just learning. And that's what we can do. And I had my own process. I used to think that I couldn't provide treatment to someone who was under the influence. Like, that was told to me by a graduate school professor. And I don't believe that at all right now. I like the fact that someone made it to their therapy appointment high. It's pretty remarkable. Yeah, I don't do mandated treatment. So that's especially important, right? So again, I think when you use the word sobriety, even though the intention, I think the intention is spot on, but it does create this mental dichotomy between you're either sober or you're not. And for some people may consider themselves in a recovered place and still intermittently use a substance.
Correct.
And sober doesn't leave room for them.
Right.
So, what do other people think? Or other questions too?
So Amber, I think that was a good answer. I think that Steve has provided some definitions in the chat there that other organizations have used to try to operationally define what it is that you're asking about there, Elizabeth. I guess the only other thing I would add to what Amber said is just, this is somewhat of an annoying psychologist behavior, I will concede, but also sort of asking in response to your question, asking the question back to you and trying to get a better understanding of what are the goals of the program and what must a person walk in the door ready and able to do in order to achieve the most benefit from what you are creating. And so rather than leaning on a definition that Dr. Cahill or myself or even SAMHSA creates, what is the definition that is set up by you for your program that is going to allow somebody to be successful?
That's very good. And I'm definitely going to think more on that line. I like that. I know one of just a little bit what I want to create is I feel things that I have seen, people are defined by their zip code. They're defined by what they did yesterday. Mm-hmm. And I want them to know that they can be successful in a job, in a career, that they aren't defined by a zip code. They're not defined by a path that they have chosen of drug use. I want to give them hope that they can succeed.
This is just so fascinating to me. This, if I had to distill down the part of what we covered today, and we're talking about it again, it is this delicate balance between self-efficacy, the sort of presence of individual choice in sort of determining a pathway, and sort of the acceptance of the presence of a disease or a physiological condition that allows empathy for behaviors that a person is exhibiting that aren't fully under their control. And it's not either or, it is fluctuating. And to hear it sort of playing out here in our discussion, I think is, I don't know, in my own little nerdy world, really fascinating to see. We've got about Oh, I'm sorry. I'm just noting we've got about 3 minutes here until 5 o'clock, and I don't want to take all of the time, but there are a couple of things that I want to hit here before people end up taking off. We are going to have another of these in this series that is already scheduled. So next Wednesday from 8 to noon, we're going to have another 4-hour training. That one is a little bit more scripted. It certainly is open to everybody, but it is really primarily aimed at people with an FDA license who are prescribers and are looking to be able to get their data waiver or X license to offer buprenorphine for people struggling with OUD. It'll provide the first 4 credits out of 8 if you are a physician. Are we still at 24 for the APCs? That's not our rule. That's the feds. But it'll provide the first 4. It will. Oh, sorry, I'm getting corrected. It's not an FDA license, it's a DEA license. Thanks, Dr. O'Reilly. But you know, you can tell I'm a psychologist who doesn't have one. But in any event, it will provide those 4 hours to kind of get you on your way. It will also have an additional 4 hours of CME credit available, similar to today. On that note, Julia Reichel just sent out to folks who participated today a document that has a QR code that you can scan for the app to be able to claim your CME certificate. It also has for each individual the 8-digit code that you can manually enter to get that certificate. So sorry to jump in with those logistics, but I think it's an important plug, and I really hope to see some of you folks next week. If you know somebody who you think might be interested, especially if they have a DEA license and they might be working towards their X, please invite them to come. It's free to them, and the more the merrier. Any other thoughts or discussion topics for what we talked about today?
I did put in the chat like a brief Department of Health guide from New York that's so well written and is like the Cliff Note versions of Amber's talk. It's just so it's really well done, and it might be good to share with both patients and your colleagues just to give them a sense of like what you're trying, you know, what the efforts are toward. Anyway, it was very, very cool. I'm psyched we get to spend more time with you at some point soon.
Wonderful. And I realize that it is 5, so I appreciate that folks have to get going. If there are follow-up comments or questions that people have and want to continue this conversation, I will extend my, you know, I'm happy to correspond by email. You can find that in the link there. It's just my name, james.anderson@bassett.org. I assume that Doctors Martin Cahill are also willing to continue the conversation if you email them.
Yes.
Thank you very much to everybody. Amber, Steve, any parting shots?
No, I love the crowd and just the diversity of what people are doing, and yeah, I'm just, you know, that's awesome.
Very, very psyched for your community, and you're going to build something that lasts for has such a legacy to it. Thank you.
All right. Well, on that note, everybody, we try to be respectful of time here. We work hard at this work, but we know that everybody has other things going on as well. So have a great evening. We hope to see you next week, and please email with any questions.
Thank you so very much.
Be well. Stay well. Thanks, everyone.